Good evening, everybody, and welcome to this session. In order not to have interruptions, I have shown you my video. I believe you're seeing my video, but I will remove the video so that the network will not disrupt our session. Okay? Are we fine?
Good evening, ma.
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am. Good evening, ma'am.
Yes, ma'am.
Good
Good
evening,
evening, ma'am.
We are
So,
fine, ma. And you?
Ifeanyi, are these all that I'm expecting? There are 39 of you. Can I start?
Prof, we're expecting up to 200 plus, but they will be joining as we progress.
Wow. Up to 200. Well, we've reached 53 now, and it's already 6:30. So we start when they come, we can. Maybe I give you another.
Ma, you're muted. You're muted.
Okay. So if we are more than 200 and only this number is available in the session, I think I should wait a little. Or we start. So good evening and welcome to this session of discussion. Your lectures are fully loaded, so I don't know how we can finish these four big topics. Have you seen it? Infant care, to look at nutritional requirements. Let me put it here. There's infant care, another infant care. We are looking at the nutritional requirements for children. We are looking at breastfeeding the children and the social requirement, breastfeeding practices, and complementary feeding practices. So these are big topics. So it will take us some time to discuss all of them and see how it is. I'm Alice Nte. I'm a consultant pediatrician at the University of Port Harcourt and the University of Port Harcourt Teaching Hospital and Professor of Pediatrics and Child Health at the Department of Pediatrics and Child Health, Faculty of Clinical Sciences, College of Health Sciences, also of the University of Port Harcourt. So you are welcome. We may not have time to introduce ourselves because if you are 200, then the class is large and we may not be able to introduce all yourselves and so on. So I want to welcome each of you and congratulate you on your successful admission to do this master's program in maternal and population health. It is very take it seriously because some men used to ask, why are we only talking of maternal health, child health? What of the men? But the fact is that when we make the system favorable for women, the men and others gain from that system. For example, the sphygmomanometer we use to measure the blood pressure of a woman during antenatal period will also be used for measuring the blood pressure of a man. So it is for all of us, but we are focusing on the more vulnerable people. So we'll have a little introduction, look at what infant care entails, the nutritional requirements of infants. Let me put on my video, please. The nutritional requirement of infants and young children in the context of global development, nutritional requirements of infant, the nutrition of infants, then their requirements, breastfeeding practices and the revised 10 steps, complementary feeding, we look at some references. So that is what we do. So there's something wrong. My slide is not moving. I don't know why. Let me see. Okay. All right. So the World Health Organization noted in its introduction on infant and young child nutrition that every infant and child has the right to good nutrition according to the conventions on the rights of the child. And if you look at the rights of the Nigerian child, you also see that the right to nutrition is not a negotiable right. And undernutrition is associated with 45% of child deaths, and with current trends in Nigeria, it may be contributing to a larger proportion of under 5 deaths. And that is why we have to work hard to mitigate the occurrence of malnutrition in children, especially under 5s, and also improve the management of those already affected so that the associated mortality can be reduced. Globally, in 2022, 149 million children under 5 were estimated to be stunted, too short for their age. 45 million were estimated to be too wasted, too thin, and 37 million were overweight or obese. So you can see a mixed pattern of malnutrition, those who are undernourished and those who are overnourished. And when we're talking of the nutrition of children, we're looking at the undernourished, the well-nourished, and the overnourished children, so that every child's right to optimal nutrition will be guaranteed. We noted sadly, however, although that World Health Organization has said that children everywhere should be exclusively breastfed in the first 6 months, only 44% of infants globally are exclusively breastfed. And in Nigeria, it's only 29%. So we're even below the global average. And the children are also supposed to receive adequate, safe, complementary foods. But in many countries, less than a fourth of infants aged 6 to 23 months of age meet the criteria for dietary diversity and feeding frequency that are appropriate for their age. If you note here, they are talking of complementary feeding. We are not using the word weaning foods. So although they have put weaning in your topic, we have removed it to put complementary feeding. That is the term that is currently being used. And it's noted that over 820,000 children's lives could be saved every year among other if all children 0 to 23 months were optimally breastfed. And that breastfeeding improves the intelligence quotient, school attendance, and is associated with higher income in adult life. And that is why we are discussing. Just imagine something that will be responsible for the death of 820,000 children. It means that if we invest in promoting optimal breastfeeding practices, we can improve the survival of children. I said that improving the development of children and reducing health costs through breastfeeding results in economic gains for individuals, families, as well as the nation. That's why I believe all of you know that we celebrate World Breastfeeding Week, and we are talking of baby-friendly hospital initiative, 10 steps to successful breastfeeding, and several other activities to improve breastfeeding. And that before, people used to want to stop at, we say breastfeed your children until they are at least 2 years old, but now we want you to extend it to 3 years to ensure that the benefits the child can get is optimized. Why is it so? Because undernutrition is estimated to be associated with 2.7 million deaths annually. Undernutrition, you know, I told you not breastfeeding is associated with 820,000 deaths. Now, when a child is undernourished, 2.7 million of them are likely to die. That is 45% of all deaths. And that infant and young child feeding is a key area to improve child survival and promote healthy growth and development. And you know, we're talking about child survival strategies. So breastfeeding is one of them. and we must look at it and ensure that it is optimally done. Now, the first 2 years of the child's life are very, very important because adequate nutrition reduces morbidity and mortality and reduces the risk of chronic diseases like diabetes, hypertension, and other ones, and helps the child's overall well growth. So, breastfeeding optimally is very, very important, and unfortunately, children in different parts of the world endure unequal survival chances, with those in sub-Saharan Africa being on the average 18 times more likely to die than other children. So we need to pay attention to what happens to the children in sub-Saharan Africa. My system is hanging. I don't know why. Let's see. Okay. Was it pause? Okay, sorry. So if you look at this picture now, you can see the deaths. How many newborn adolescents died in 2022. The literature gives it about 2 years back that the entire year, 2.3 million children, 4.9 million under 5s, and 0.9 million adolescents. So you can see that the main deaths occur in the neonatal and under 5 period. That's why we are talking of the child survival strategies, infant care, infant welfare, breastfeeding, immunization, and those things that target this age group to ensure the survival. And if you look at this last page, it says every year 6.3 million 6,300 children die as newborns, 13,000 die as under 5s, and 2,500 adolescents die. So that translated to one neonatal death occurring every 14 seconds. So count the number of seconds you are going to use in our lecture today of about 1 hour. Know how many newborns that have died before I finish delivering this lecture. And during that same period, it says 1 under 5 death occurs every 6 seconds and 1 adolescent dies every 35 seconds. The summary of it is that many children are at risk of death, and we as those undertaking this master's program must pay attention to these deaths and their causes to help the children to survive. So you can see that from 1990, efforts at reducing the deaths of children aged 1 to 59 months, that is children under 5 minus the neonatal period, has continued to reduce the deaths till 2022. But you can see the deaths range from millions and has been going down gradually. So we must continue to invest in the child survival strategies to ensure the survival. And these deaths, you see, the progress has been very significant, with death reduction by the global reduction by 51%, but the sub-Saharan Africa by just 53%, but in Southern Asia by 62%. So in all the regions, the African rate of reduction of child death has been lower compared to what happens in Southern Asia. So maybe people will help us. And if you look at this, where are the children likely to die as under 5s? This is Africa where we are. So more deaths occur in sub-Saharan Africa and Southern Asia. So we need to pay attention to our region. And that infant care, nutritional requirements of infants, breastfeeding, weaning are critical to improving the survival and growth and development of children. The morbidity and mortality indices, including nutritional indices in children, are listed among the indicators for assessing global and national development goals and targets. That's why the Sustainable Development Goals includes targets related to nutrition, related to child survival, and even the Nigeria's national strategy for reproductive, maternal, newborn, child health, and adolescent health, that is the RAMCA documents, envisage that we must be able to ensure optimal well-being through optimal nutritional practices. So if you go to the Sustainable Development Goals, Goal 2 says end hunger, achieve food security, and improve nutrition and promote sustainable agriculture. So it says by 2030 we should end hunger and ensure access by all people, in particular the poor and vulnerable situation, including infants, to safe, nutritious and sufficient food all the year round. So I want you to think about what is happening in our country, whether we are making this to happen so far. And it says by 2030 we should end all forms of malnutrition, including achieving by 2025 internationally agreed targets on stunting, wasting in children under 5, and address the nutritional needs for adolescent girls, pregnant and lactating women and older persons. So you can see that nutrition, improving what happens, is key to the attainment of the sustainable development goals. And these are the indicators: prevalence of undernourishment, prevalence of moderate to severe food insecurity in the population, prevalence of stunting among children, using height for age less than -2 z score. That is a moderate form of stunting, not the severe one. Prevalence of malnutrition, weight for height less than +2, or less to our height, greater than or this. So that form of the obesity, or underweight forms of malnutrition. Then we talked of anemia in children. So these are part of the indicators that we use in measuring the sustainable development goals, and it includes reducing the death in women, children, epidemic, tuberculosis, and all these ill deaths are having malnutrition as part of their contributory factors. So when we address malnutrition, we'll be able to contribute to the attainment of the goals of the sustainable development goal. And looking at it, let's go to our nutrition goal on infant care. So infant care is critical to ensuring optimal health, growth and development of children, especially under 5. And infancy is a period of birth, the first 12 months of life, that is 0 to 12.999 months. But I'm sure what you are talking about, sorry, the environment is a bit noisy. So infant care ensures appropriate care with adequate nutritional, preventive, promotive, curative and rehabilitative service. So it is targeting children in the first 1 month of life. But you see, because we cannot quite separate infants from under 5, we are looking at the whole under 5 period. And in Nigeria, there is no separate infant clinic, but it's the clinic that provides immunization services, growth monitoring, treatment of diarrhea and other diseases, and those services are documented in the child health card. And they include essential newborn care for babies in the first 1 month of life, which include skin to skin contact between the mother and the baby from the time the baby is born, and this improves a chance of the survival of the children, keeping the baby warm, milking the placenta, the cord before cutting milking the cord before cutting it to ensure the child gets more blood, and promoting bonding, initiating breastfeeding within the first 30 minutes of life. So that is what it is. And that the tips you need to do during this period is that the baby should be wiped. No, we are talking of infant care. As soon as the baby is born, the baby should be wiped, clean, and we delay the birth in places that are cold. Don't bath the baby immediately. Keep the baby warm, covered, then breastfeed the baby, and the baby should be examined by an experienced person. Many babies go home without being examined. Babies should be examined. The umbilical cord should preferably be kept cold, but I know that recently WHO has recommended the use of chlorhexidine gel, which the Nigerian government has also adopted. Then the baby and the mother should stay together, skin to skin, as much as possible. Must wash hands and then understand the danger signs, so that like fever, fast breathing, refusal to feed, change in the color, reduced movements. Once any of those things occur, the baby should get attention. Then all births should be registered. We should follow the advice of the health worker. The child should go regularly for checkup, should be immunized. You give supplements like vitamin A supplementation, deworm the child. Those who need folic acid and iron, the child should be screened for infectious diseases and protected from getting infected. And we should support those who have disability, and if the child is sick, we should see health care immediately. But in Nigeria, many children have not been able to get this. So the recent demographic and health survey shows that the under 5 mortality rate, which was 193 in 1990, just reduced to 110. But the infant mortality rate reduced from 87 to 63, and the neonatal mortality rate to 41. And looking at this, this means that we have not yet gotten close to the attainment of the Sustainable Development Goals, which say we should reduce the neonatal deaths to about 12 per thousand live births and under 5 mortality to 25 per thousand live births. So we need to do a lot more to be able to bring these indices closer through improved care for children. And one of the areas that will help the country is what happens with antenatal care. You can see that percentage of women who receive antenatal care is just 63% as at 2020 from the 2024 demographic and health survey. But how many return to the hospital after checkup? 43%. How many children that were, how many women who had antenatal care deliver in the hospital? 46%. That means that 54% of women deliver outside, and that increases the risk. That's why we're still very far from attendance reaching the sustainable development goal. So you can see it here, just 43% delivering in the hospital. So in improving infant care, we have to be able to improve those who register in facilities and ensure that the children are registered. Look at only 40% of children are registered. So we don't know what happens to 60% of our children. We have no record. Now, if it's a time of school, people will go and say affidavit, oh, the child was born. So, but we need to know how many are born so that we can arrange for immunization and so on. Now, the demographic and health survey shows that children are supposed to get these basic vaccinations: BCG, 3 doses of diphtheria pertussis containing vaccines, which we call pentavalent vaccine, oral polio vaccine, and 1 dose of measles. That is a basic. Then the full vaccination as at that 2023 survey included BCG, the pentavalent vaccine, oral polio vaccine at birth, 3 doses of oral polio vaccine, 1 dose of measles, birth dose of hepatitis B vaccine, 2 doses of inactivated polio vaccine, 3 doses of pneumococcal vaccine, 1 dose of yellow fever vaccine, and 1 dose of meningitis vaccine. But you know, recently the immunization schedule was updated so that children are now supposed to receive 2 doses of measles containing vaccine, which is measles and rubella. And they're also supposed to receive malaria vaccine. So that increases the vaccination requirements for the children. But look at that basic dose. How many? Those who were fully immunized by the basic dose, what did we have? Only 34% in the rural, 48% in the urban, 39% fully. And then those who were fully immunized according to the national schedule, which we talked about, is just 14% rural, 28%, and then 20% national. That shows that a significant percent, 80% of Nigerian children are not being fully immunized. So you will understand why they are dying, and that there is a 30% children that are not getting any vaccine at all, and they are called the 0-dose children. So as stakeholders in this matter, we need to track those 0-dose children and be able to immunize them. Still talking on infant care, look at the treatment of diarrheal diseases. The people among the children who had diarrhea, only 60% sought treatment. 47% had ORS, and the complete treatment for that, which is ORS, zinc and continued feeding, only 16%. So several of the children are not getting appropriate treatment. There are many children under 5 with fever sought for care, only 16%, you know. Now, of those people who sought out for care, only 20% had blood taken for testing for malaria, and 57% took anti-malaria. So you can see the care practices are still inadequate. Now look at the nutrition of the children. How many? 48% are stunted in the rural area, but combined stunting rate is 40%. Now 8% wasted, 27% overweight. So that shows we have a problem. In fact, if you look at this picture between 2018 and 2024, you can see that the stunting rate increased from 37% to 40%, the wasting rate increased from 7 to 8%, underweight rate increased from 22 to 27%, while overweight reduced by 1%. That shows that there is a problem with our nutrition, so we need to pay attention to hold to the children. Now look at the exclusive breastfeeding, which is very pivotal. Only 29% are being breastfed, as against the 50% rate that we're supposed to achieve by 2025. And the feeding practices, the minimum dietary requirement, only 12% meet that goal, and 41% consume sweet beverages and 24% consume unhealthy foods. Look at insecticide treated nets, only 59% had at least one. And then the children who slept under mosquito net, 43%. I know some of you too don't sleep under net and you don't put your children under net, but that means that a significant percent of the children are exposed. So when we look at the causes of the deaths of the children by verbal autopsy, the newborns, you can see sepsis, pneumonia, intrapartum injury, and jaundice, because they are not being, the mothers didn't have antenatal care, they are not being delivered in the hospital, parents seek for care late, and so the children die before much can be done for them. And if you look at the under 5s, you have malaria, diarrhea, pneumonia. These are the 3 major killers for the same reason. They don't sleep under net, they don't get the vaccination, they don't seek for care early. So you have a lot to do. And for us, the infant welfare clinic that we talk about, provides immunization services and several of these services, and they document these services through the child health card, which unfortunately we are calling immunization card. And if you look at it, in addition to recording the immunization of the, you can see the health facility, the mother and the health worker or the father, they talk about the immunization, talk about birth registration of the child, talk about the details about the child's family, the father, the mother, the reasons, the vaccines the child has received, and the adverse events following the vaccine, the reasons why the child needs extra care, that is what happens to the other children, and then how to treat diarrheal disease, because diarrhea is a big killer of children. So we have that on that card. Then if you look at the next part of the card, in addition to immunization, you can see the growth chart, because we told you malnutrition was important. So for all of us, you need to pay attention to that growth chart so that a child should be growing well. We also talk about the development of the child. You see, they've shown the developmental milestones showing how the child should be growing. Some people call it the road to health chart. So as the child is growing well, the child will be following that road. And if you look at that card very well, you need to look at it well, you will see 2 dotted lines, the upper one, black one, solid one, and the broken one. The solid one is the weight the boy should have, while the broken one is the weight the girl should have. And it has interpreted it for us that it should be going up to show that the child is growing well. If it is flat, the child is not gaining weight as expected, and it is worse if it starts declining. So we need to pay attention for the infant welfare. And Nigerian government adopted the World Health Organization's child growth standards. So you have the weight for age, you see, the growth standards by percentile and by Z chart. So the children that are growing, you see this is the -2 Z score, -3, then the 0, +2, +3. So the children should grow according to those standards. You check the weight for age, weight for length, and so on. So you monitor the children and classify their nutritional status as part of the growth monitoring. So what does that growth chart help us under infant care? It dictates early growth faltering and prevents underweight, identifies underweight and children who need special attention, identifies severely malnourished children who should be referred, the causes of weight loss like those who have been ill, diarrhea, unimmunized, and educates the parents on how to take care of the children. So this is the scenario of the child infant welfare and the child care, so that we reduce morbidity and mortality. So what do these children require for their nutrition? The nutrition varies according to the age, but we say that every child has a right to optimal nutrition and that we must breastfeed the children properly. I have already told you this in the introductory slides, and that for 2030, the world set a global nutrition target of ensuring that 40% reduction in the number of children who are stunted compared to 2012 baseline, 40% reduction, 50% reduction in anemia in women, 30% reduction in low birth weight, reduction in main ten ance of overweight in children less than 5%. Already, because of bad nutritional situation, the number of percentage of malnourished children is reducing. So we say we are achieving that goal not because we are really making effort, but because the children don't have food to eat. But we should increase the rate of exclusive breastfeeding to at least 60%. We were only at 29%. So between 29 and 60, you see we have 31% increase we must get to attain the 2030 goal. And we should reduce and maintain wasting in children under 25 years of age to less than 5%. Our own current rate is more than that. So we have a lot to do. So what are the requirements of children? Daily caloric requirement is calculated by age, sex, and the activity level of the child. And I showed you in looking at the growth chart, you can see that there are differences in the growth chart. If you look at that chart I showed you, you can see the blue ones are for the boys and the green ones are for the girls, because their growths are different. And if you look at that our national chart that I showed you, you can see the dotted lines. The dotted one, lower one for the girls, and the bold ones are for the boys. So the growth and the requirements are different for the males and the females, and so we must know and feed them better so that we reduce the risk of death. But for the children between 2 and 3 years of age, the recommended daily caloric intake is between 1000 to 1400 kilocalories per day, and it increases with age. By this time they are crawling, they are walking, some have started schooling, and that the children have their growth spurts, and during those growth spurts they require more food. That's why teenagers, adolescents usually take a lot of food, and we must be able to give them. So for the children between 11 and 12 years, their caloric intake increases between 1800 to 2200 per day. But generally the caloric need is for an infant 100 kilocalories per kg per day, 1 to 3 years 80 kilocalories per kg per day, 4 to 5 years 70, 6 to 8 years 60, and 9 years plus for 35 to 45. That shows that as the children increase in ages, their caloric requirement tends to drop because the growth increases, the growth in the children, the growth rate reduces, and we need to understand what they need. This is important when we are calculating the nutritional requirements for the children. So the daily recommended intake depends on the age, activity, and then where the children are, the humidity. You must include water in part of what the child must take, because water is required. Unfortunately, many people don't give children sufficient water, especially in an environment where access to tap water is not there. People tend to buy pure water, so it is money. And it says that about 75% of children fail to take the recommended amount of water. So for children weighing up to 10 kg, we need to give them 100 ml per kilogram of water per day. That means for a 10 kg child, we need to give 1 liter of water. So you know how many sachets of pure water that would be. Then between 10 to 20 kg, they need 100 ml per kg for the first 10 kg and 50 ml per kg for every kg above 10 kg. So a 20 kg child will need like 1,500 ml of water. So as the child grows more, the fluid requirement reduces, and we need to know what it is. So there are 8 classes of food a child must get the foods from. I told you that the children did not get required food for their different ages. So for the children, we must continue to breastfeed them up to 3 years. So one class of the food is breastfeeding. Then we need to give the child 2 to 3 meals a day, and then healthy snacks, that a growing child needs increasing amounts of different foods, and we must give at least foods from 5 groups, including breastfeeding, from the 8 identified food groups. And these 8 groups are breast milk. It is compulsory for these children we are talking about, infants and young children up to 3 years. Breast milk, grains, roots and tubers, you can see them, grains, roots and tubers, legumes and nuts, vitamin A containing food, dairy products, milk, fish, flesh, eggs. We must add all that. Then vitamin A rich vegetables and other fruits and vegetables. So we need to get food from these 8 classes for parents to be said to be feeding the children optimally. So they need it. So the carbohydrates, how much do they need? Na about 50 to 55% of the requirement should come from carbohydrate, and that each gram of carbohydrate has 4 kilocalories. And we should not give the child maybe big bowl of garri, big bowl of akamu, no protein, no milk, no other categories of food. So we need to give the children a lot more of all the other foods to ensure the diet is balanced, and that we should limit simple sugars. Don't put too much sugars to the food of the child. Add legumes, whole grains, vegetables to fill in the energy requirements with carbohydrates. Then we also need to give the children protein. About 30% of dry body weight is contributed to by proteins, and is required for the muscle, the bones, the ligaments, even the making of the blood cells. Almost every part of the body requires protein, and that the daily recommended amount of protein is 1.6 gram per kg for an adult. But in many families, the fathers eat more meat and chicken and fish than the children. So we need to give the children a lot more protein to ensure that their nutritional needs are met. And these are the foods: poultry, milk, cow milk, goat milk, liver, yogurt, eggs, cheese, dry meat, and fish. So all these different categories should be added as animal source food. Then we need the legumes: peas, beans, lentils, and other nuts and co. So we have a lot of this. We should look for them and add. Then for the fat, we know that fat contains glycerol and fatty acids, and they are high energy containing food. So 1 gram of fat gives about 9 kilocalories. So we want the children to take only about 25 to 30% of their daily calories, which should come from meat and from fat, and saturated fat should not be more than 10%. We know cholesterol can be synthesized in the body, and a high fat diet can lead to development of obesity, which is associated with cardiovascular diseases. So we must reduce the fat intake in those foods, the sugar intake. We should encourage fruits and vegetables for the children. So these are the fats and oil. You can see them: coconut, margarine, cheese, and butter, that's the vegetable oils. Then we also need to add fibers to the children's food from each age. They must take at least the age of the child with 5 grams to make the children able to take more fibers to encourage them to be healthy. And these are the foods: pumpkins, carrots, sweet potato, pawpaw, mango. So you see what is happening. Because these foods are expensive, many parents are unable to afford it. Then we also need to add minerals and trace elements, calcium, magnesium, zinc, other elements. So copper, we need to add this in various amounts to the children to ensure that they are optimally fed. And we've noted that inadequate calcium and phosphate intake leads to the development of rickets in the children, and lack of vitamin A leads to damage to the eye. So we need to pay attention. And to help us now, like when children have that, we give them zinc supplement. We routinely deworm the patient to reduce iron losses. Some children, we give them iron supplements. We give folic acid supplements for sicklers and those at high risk, and we give vitamin A supplementation routinely to help them address these mineral deficiencies. So we need to pay attention to those requirements and meet them. So we need to take actions to ensure that we put that nutrition well, by ensuring early initiation of breastfeeding, exclusive breastfeeding for 6 months, complementary feeding, till the child is 2 years or more, and feeding the sick child frequently, giving vitamin A supplements every 6 months for the next 5 years, then adding micronutrient powder for the children, preventing and treating infectious diseases, deworming them every year, when they do maternal, newborn and child health week, and ensuring they sleep under insecticide treated net, and treating diarrhea, so that we can reduce the risk of malnutrition in the children. Now, when we talk about breastfeeding, because it's also a separate topic here, we are things you should do for the mother. So when you do, you say breastfeeding is good for the mother's health and the health of the baby. The mother should exclusively breastfeed in the first 6 months of life, and when the baby is older, we should continue breastfeeding with other foods. The mother can breastfeed directly, or she can express the milk into a cup and feed the baby. And if the baby is sick, you continue to do express breast milk and ensure the baby is used. And it talks of using contraceptive condoms for the mother that is breastfeeding. So you can see the early initiation of breastfeeding and so on, and then proper attachment of the baby, allowing the baby's mouth to open, take the areola in and suckle the baby as much. They've given you the signs of good attachment. Babies will touch the baby's hip, the baby wait for the mouth is open, then move the baby's bring the breast from below, aiming to the child's mouth, and the baby should take the areola and a chunk full. Then, to see that the baby is well attached. If the baby is refusing to breastfeed, there are things you should do for the baby, but you must breastfeed day the net and breastfeed. But to breastfeed optimally, the mother also need adequate nutrition during pregnancy and childbirth. She needs to be tested for HIV in case she's infected. She can still breastfeed if she's on highly active antiretroviral drugs. She needs to protect herself to ensure good hand washing, sleep under mosquito net to ensure she feeds well. So the recommended breastfeeding practice is that you should start breastfeeding, which you call initiation, as soon as the child is born. Exclusively breastfeed in the first 6 months of life. Continue breastfeeding for 2 years or more, that is up to 36 months, with introduction of complementary foods from the age of 6 months. And that the mothers who are HIV infected, before now they will tell them not to breastfeed, but now what they do is that the mother should start antiretroviral medications, which will now allow her to exclusively breastfeed for 6 months and continue with other foods till the child is 12 months old. Then she stops breastfeeding. But if the baby is already infected with HIV, the baby can continue to be fed like every other children. Unfortunately, in spite of that knowledge, in Nigeria, the last demographic and health survey showed that only, see, I told you, 29% of babies by 6 months were exclusively breastfed. So these other ones gave breast milk and plain water. This red column, breast milk and plain water, breast milk and solid food. Then the children were not even breastfed at all. So you can see that, then breast milk and non-milk liquids. So you can see all the wrong feeding practices our children are going through, and that's why we have a lot of them being malnourished. So what are the components of milk? The breast milk does not only provide nutrients, it also protects the children from infection. So in addition, it's rich in cholesterol, which is useful in breast development and helps. It is very important that there are different types of milk and their components differ. The first milk that comes out is the colostrum, produced immediately after birth. Before the milk starts, usually 2 to 3 days, it is thicker, yellowish or creamy in color. It contains its protein rich immunoglobulins and helps to protect the baby against infections. It has a high content of fat soluble vitamins, minerals and others. So colostrum is really energy dense and rich, and the immunoglobulin pass from the mother through the breast to the baby to protect the baby against infection. Now, between the colostrum and the full milk is a transitional milk, which is produced within 2 to 4 days. It gradually replaces the colostrum, containing less amount of fat and increasing amount of water and calories than colostrum, to make sure the child receives adequate nutrition. Then we now have the mature milk, which is fully yellow. Is a milk produced from after the first 2 weeks of life, and about 90% of mature milk is water. It helps an infant remain hydrated. So if a mother can produce like 1 liter of breast milk a day, and that 90% of mature milk, that means the child can have 900 ml of water. And I've already told you that the child requires 100 ml per kilo of breast milk of water per day. So a child who is being breastfed can really have all the water contents from breast milk. So the other 10% of breast milk contains carbohydrates, proteins, fat, which support growth, and that similar to cow's milk, the main carbohydrate on mature milk is lactose. Human milk also contain vital fatty acids such as docosahexaenoic acid and arachidonic acid. The breast milk also has lactalbumin, which is important in the development of brain. The protein is human protein and is very, very important. Now, the mature milk is of two types: the fore milk, which starts early, and the hind milk. They contain more water. The fore milk contain more water to satisfy the taste and a lot of vitamins and proteins, while the hind milk is more dense in fat and helps to satisfy the child. The breast milk also contains vitamins and minerals. So their absolute quantities are small, but because the child takes them frequently, the child tends to get their requirements met through these ones. And the baby also has digestive enzymes, which helps to make the baby absorb all the food. So you can see the water content of breast milk about 90%, which means it will meet the needs for the baby. Then it has lactose, protein and fat, that is for breast milk. And that the content of breast milk, you can see this is infant formula: water, protein, carbohydrate, deoxyribonucleic acid, fat, vitamins and minerals. But beyond that, breast milk has the enzymes, growth factors, antiparasitic agents, anti-allergic, antiviruses, hormones, antibodies. That makes breast milk superior to any infant formula, and that also makes it to remain the most important food in the most vulnerable period of the child's life, the first 2 years of life, that we must continue to give the child. You can see the differences between colostrum, thick yellowish milk. This is transitional milk, and this is the mature milk. So you see the colostrum with a lot of protein, a lot of fat, protein and carbohydrate. The fore milk contains less fat, protein and carbohydrate. Then the hind milk contains more fat. So the baby that is supposed to be well fed should take all the milk, the colostrum, fore milk and hind milk, so that we'll be able to get the baby very well fed and cared for. And the content, the baby, the human milk, contains less protein than cow's milk and goat milk, because their own babies are bigger and they need more protein for them to grow and grow big. Then if you look at the breast milk, has a lot of lipase and essential fatty acids, whereas in cow's formula they have to add those essential fatty acids for it, but it's not comparable because the lipase helps to digest the fat, which formula does not have. So the vitamins, the breast milk has a lot of vitamin A, vitamin C and a B group of vitamins, whereas the cow's milk has more B vitamin, little vitamin C and vitamin. That's why vitamin A supplementation starts when the child has attained the age of 6 months. And then the iron too, even though breast milk and cow's milk may contain the same amount of iron, the percentage iron absorbed in human milk is almost 50% compared to 10% in cow's milk. So you can see the milk in iron in breast milk is more available. Then the protein contents are also different. For human milk, you have 35% casein, which is soft, forms soft cores that are easily digested. It also has alpha lactalbumin and anti-infective processes, and that lactalbumin is contains lactoferrin and lysozyme. All those ones, the anti-infective, which are the whey proteins. But in cow's milk, you just have a lot of casein and beta lactoglobulin. So the cow's milk does not contain sufficient of what the child needs, and it's also difficult to digest. That's why the children fed with animal milk tend to have constipation and other complications. So the differences are well spelled out here. So we encourage exclusive breastfeeding, which means giving the baby only breast milk and no other milk or things in the first 6 months of life. That this milk can be either by a wet nurse feeding an express breast milk or a donor milk. It is still part of the exclusive breastfeeding, although drugs, vitamins, prescribed medicines are allowed, but herbal fluids and other traditional medicines counted as fluids are not allowed, and water is fluid, so it is not also allowed under exclusive breastfeeding. So between the second year of life, the child still needs breastfeeding, because if the child is able to take 500 ml of breast milk, it will provide 31% of the energy need, 38% of protein needs, 45% of vitamin A needs, and 95% of vitamin C needs. That's why from 6 months we tend to give the child vitamin A supplement, because only 45% is being provided, and that from that 6 months the child needs to be to have complementary foods to add up to cover the energy and protein gaps in the nutrition of the child. So the terms we have looked at it for it. So the benefits is that it's a perfect nutrition, it's easily digested, efficiently used, and protects against infection. Then breastfeeding itself enhances bonding and development, delays a new pregnancy, protects the mother's health, and is cheaper. So we really need to protect it. Now, these benefits, we can highlight it further with all the contents. The Lancet series show the protection from breastfeeding that is personalized. So a child in place A will have protection against the infection that is there because the mother's bacteria stimulate the formation of antibodies, immune cells, and which are passed on through breast milk to the baby. And baby breastfeeding serves among all the child survival strategies. Breastfeeding alone reduces 13% of under 5 days, and I told you that breastfeeding optimally will reduce 820,000 under 5 days in the first 1 year. So the colostrum is important because it is antibody rich, has many white cells, has purgative effects, many growth factors, and is rich in vitamin A. And when we give the children the colostrum within 1 hour, the risk of death is 0.7, and as we delay the breastfeeding, we increase the risk of death in the baby. That's why we want early initiation of breastfeeding, and that when we exclusively breastfeed the children, the risk of death is reduced. So there are several advantages of exclusive breastfeeding, which I have alluded to. But concerning the infection, the mother gets infected and produces white cells go to the mother, produce antibodies to protect her. Some migrate to the breast, and some of the white blood cells make antibodies there, and then through the breast milk the antibodies reach the baby. That's why even when a mother is infected, mother is not well, the baby should continue to be breastfed. Even when the baby is not well, the baby should be breastfed because the antibodies from the mother will pass on. And this picture demonstrates how breastfeeding protects against the common killers of children, diarrhea and pneumonia, and also ear infection. That breast milk is like a shield that protects the children. It also improves it that breastfeeding would prevent more than 54% of diarrheal episodes and 32% of respiratory infections. It reduces hospital admissions for diarrhea and respiratory infections. Even for the mother, I've told you, it reduces the percentage of deaths in the children, 57% of infants less than 6 months, and it reduces mortality in children less than 3 months. So breastfeeding is an unparalleled way of protecting children and help. And you can see that even when you breastfeed the child, intelligence quotient continues to be high, increasing higher between 8 and 15 years, more than the children who were not breastfed. So it delays the menstruation in the mother, and when the menstruation comes, breastfeeding reduces the risk of her getting pregnant. It reduces the reduce it could prevent 20,000 deaths from cancer, breast cancer. So we should know how important. Economically, it is also beneficial. But when we don't breastfeed, the risk of mortality brings to the mother mortality, respiratory infection, diarrhea, obesity, diabetes, asthma, childhood cancer, lower intelligence and abnormal development, risk to the mother, breast and ovarian cancer, diabetes, early return of pregnancy and fertility, less time between pregnancies and difficulties in cleaning and preparing feeding bottles, financial burden. Then for it is non-economic burden of chronic diseases important. So these are the dangers of not breastfeeding the children, and we want to avoid those dangers. There are several factors that contribute to it. So we need to provide a circle of support, the family and social network, healthcare, government legislation, response to crisis and in emergency, and workplace and employment. They need to work in synergy to help protect the women and encourage them to breastfeed. And there is the 10 steps to successful breastfeeding which have been set up that we should comply fully with the International Code of Marketing of breast milk substitutes, have a written breastfeeding policy, establish ongoing monitoring support for the breastfeeding to know what is happening, ensure that staff have sufficient knowledge about and competence to support breastfeeding. So these are management steps you need to do. Then clinically, there are some things we need to do to help breastfeeding. For the women that meet us in the clinic, we have to discuss the importance and management of breastfeeding with them and their families. We should facilitate immediate and uninterrupted skin-to-skin contact so that the mothers can initiate breastfeeding as soon as possible after birth. We should support mothers to initiate and maintain breastfeeding and manage common difficulties. Maybe they have breast engorgement, nipple fissures, the child not want. All those things are difficulties. We should help them. But above all, we should not provide breastfed babies foods or drinks other than breast milk unless medically indicated. So they must only take breast milk as food and drink. We should enable the mother and the children to remain together 24 hours a day. Then we should also support mothers to recognize the needs and respond to the needs for their children's feeding. Some people say, oh, I only breastfeed 3 times. You need to breastfeed 8 to 12 times a day. So if the baby is crying, breast milk should be offered, because breast milk provides both food and nutrition and comfort. We should not give artificial teeth or pacifiers and feeding bottles to infants and young children. And we should coordinate the discharge of children so that the parents and their caregivers will have timely access to the breastfeeding and ongoing support for them. So these are the tips that WHO offered for the children. No, we have to follow health workers' advice, breastfeed exclusively, don't give other foods. Then from 6 months, we start giving small amounts of energy food, vary the food, continue feeding with cup and spoon, and encourage the children to eat, not force them. Talk to them while they are eating, maintain eye contact, and help them to learn to feed themselves. So we talk about complementary feeding, which is the last one. That shouldn't take us much time. I know it's almost time, it's almost gone. So you can see the baby is being fed with a spoon from a plate. You can see the spoon, I can see the plate, and the child is opening the mouth for the food. That is complementary food. And that in feeding the complementary food, you can see this bird here, that we don't allow cups with mouth. Complementary feeds are starting of age. You say you begin to feed at 6 months, salt well mashed 2 to 3 times a day, about 2 to 3 tablespoons. A tablespoon is about 10 ml, so about 20 to 30 ml. So it is not important to go and make a full of 50 ml and say, no, my pikin no dey eat. My child has to feed child slowly. Then between 6 to 9 months, you start teaching the children how to eat mashed food, 2 to 3 spoons a day. You gradually increase the amount of food for the child while continuing to breastfeed the child. And then they must take the child for growth monitoring and promotion, immunization, child baby clinic follow up. If they are sick, you go to the hospital. And when the baby is ill, you give small amounts of meals more frequently, including breast milk and other meals, and encourage the baby to eat a variety of foods on their own so that they can be optimally fed. And this picture shows you all the categories of food. I told you the 8 classes of food we should give to children: the egg, the milk, the protein, animal source proteins, vitamin A containing foods, the fruits, the tubers, all must be added to breast milk to the child. And when we start feeding, we shouldn't give food that is too thin. The food should have good thickness so that it will be energy dense. And you understand that hand hygiene, washing the hands, washing the plates, covering the food, and encouraging the child to eat are very important parts of doing complementary feeding. I will just quickly talk about weaning before we finish the topic. That weaning is a process of switching an infant's diet from breast milk or formula to other foods. So we don't like weaning as a term because it just means you stop breastfeeding and go other. But they have always said it's a gradual process, but we do not want a child. The child should continue to take breast milk as part of his food up to 36 months, and we do not recommend cow's milk for children younger than 1 year of age. So that fresh cow's milk is shown is too difficult, and weaning practice differ from one culture to the other. We exclusively breastfeed from 6 months. We start adding semi-solid foods. So in our environment, we add pap, we add milk, crayfish, but we should not add mixy and all those creamers to the food. You need to add full cream milk, add egg, add groundnut and other things to enrich the food to give. Don't just give akamu with salt. The akamu should be made with different grains, usually 3, guinea corn, millet and the other type. So whatever grains are available, we should use it. But you can also mash other food. You cook fried rice, you can blend it. You cook garri, yam, mash it, make it into a form. You can make it soft in breast milk so that the child can eat the food and continue to increase in the consistency of the food the child is eating. But from that 6 months, the child must take at least 600 ml of milk. If the mother is not breastfeeding, she has to make milk, either full cream milk or whatever. She does not need to go and buy infant formula. She should buy normal milk, full cream milk, not creamer, to give the children. So the WHO has put a guideline on complementary feeding, which I will share with you people, that you need that guideline to help the mother that around the age of 6 months, the child needs more energy, because by that time the child has started sitting, learning to crawl, learning to walk, learning to do many things. So, and is growing more. So if complementary foods are not introduced at that age, or if they are given appropriately, the child's growth will falter. The child will not grow as we want him to grow. So we need to make sure. So complementary foods is important because that age the child becomes more vulnerable, and ensuring that the nutritional needs of the child are met. The complementary food should be timely, start at 6 months. So it should be adequate in quantity and quality, the energy, the protein, the micronutrients we've discussed. They should be safe, prepared with clean hands, fed with a cup and plate and spoon, not feeding bottle. They should not be stored too much. Give food within 1 hour of its being made, and should be properly fed with cup and spoon, understanding the needs of the child, somebody talking to the child and helping the child to be fed. The low-cost complementary foods prepared with locally available ingredients, using small scale and co, should be able, the mothers should be able to use. You don't need to buy complementary foods that are marketed like akamu. People make akamu, you can buy the akamu, enrich it and give it to the child. So when you are buying processed food, the cost can be intensive and it is difficult for the poorer people to make. But whatever food you make, it must meet the required standards. So the food should be continued frequently on demand, with continued on-demand breastfeeding until 2 years or more. You practice responsive feeding. When the child wants, feed slowly and patient. Don't get angry. I told you 2 to 3 tablespoons of food between 6 and 9 months. So don't go and make 250 ml of akamu and say the child is not eating. Or some people will stop breastfeeding because they want the child to eat complementary food. You do the complementary food is a food that complements the space that breast milk didn't cover. So the child should be breastfed first before you add these other foods, and you gradually increase the quantity and the quality of the food and the frequency as the child grows. So there's a global strategy for infant and young child feeding which guides many policies for food. The frequency, the child needs 2 to 4 meals a day plus 1 to 2 snacks, and a variety of snacks should be used. The banana, pear, mango, yogurt, oranges should be given. So you can see there is no biscuit here. Have you seen? Because many times we give our children biscuits and things that will make them fat, you know. So the food should be appropriate. The mother should have proper information, and it should be relevant to the culture of the people. So we feed the children. It says that the immediate consequences of malnutrition include, in the formative years, include impaired growth, significant morbidity and mortality, and delayed motor, cognitive, and socio-economic development. It can also lead to increased risk of non-communicable disease like obesity. You know, we are also having diabetes, hypertension, and obesity in children. So we need to pay attention to what the children eat during this period. So for the baby whose mother is not being breastfed, during this period we need to give extra water in hot environment to increase animal source food, fish, avocado, you know, vegetable oil, nut paste are essential fatty acids. We should also give animal source other animal source food, fortified foods, vitamin A supplements, iron. We should give milk and extra meals to the child to ensure that the child is taken. Then there are children we say are in exceptionally difficult circumstances, like children whose mothers are HIV infected, children whose mothers have died, children affected by crisis, flood, and other things. Those difficult situations impair the optimal nutrition of the child. So we must pay attention to those children, and as much as possible, if the mother and the baby can remain together, and for whatever reason, even in emergencies, it is preferred to breastfeed the child. So the babies that are low birth weight or premature, they do not need preterm milk and so on. They need breast milk. The mothers with HIV, I've told you, with antiretroviral medications, they can breastfeed exclusively for 6 months and continue breastfeeding till 12 months and stop, and then you continue with other food. Children who have diarrhea, pneumonia, and so on, they still need to be fed. Adolescent mothers should also be helped to breastfeed, to feed their children. They can go to school, express breast milk and keep, and come back and feed their children. Then children who are malnourished, we need to pay attention. And then families that are suffering from various consequences of emergencies, they are in difficult situation, because we must break this undernutrition circle. From undernourished child, the child becomes undernourished as a child up to 2 years, becomes undernourished as an adolescent, and becomes undernourished as a mother, and gives birth to a child that is low weight for age. So we do not want that to happen. So we need to take appropriate actions, support the child to feed, ensure adequate hygiene. The child should eat different foods, give vitamin A, prevent and treat infections, deworm the child, use insecticide treated net, and then give zinc for ORS and so on. But when we fail to do it, fail to feed the child well, there's a risk of intrauterine growth malnutrition, underweight, stunting, wasting, and micronutrient deficiencies. And the other consequences include weakened immunity, stunted growth and development, poor cognitive development, low birth weight, and death in the baby, and also the effect on the girl child. So you can see this child with kwashiorkor from poor feeding practices. This is another one with stunting, wasting. These are children we have found in this state, you know, Rivers State. So we need to pay attention. This one is a stunted child. If you look at this growth chart. I told you the growth chart helps us to detect children with malnutrition early. But look at this child, he had gone to the hospital for immunization, but because they were not using growth monitoring and promotion, the child came with a birth weight of 3 kg here, which is within those lines of normal weight, but the child kept deteriorating. The weight went far below the line and was not picked up, and this should not happen. But we need to pay attention. See, the baby looks fine, but unless you plot the weight of the baby to know this baby is 1 year plus and is looking like a newborn baby, so we need to pick up. You use the mid upper arm circumference strips, mark strip, to monitor the child. You can see both of these children have a red mid upper arm circumference, showing that they have severe forms of malnutrition. This is what I talked to you about the trends in our country, and this is the stunting rates by different states. So it is commonest in the northern part of Nigeria. Almost 51 to 65% of children in some states in the north are stunted, but in Rivers State 12% of our children are stunted, 28% in Bayelsa State, but we are supposed to put stunting rate at less than 5%. So whether it is 12% or 65% like in Katsina State, we need to pay attention to the nutritional status of children and improve, because this whole country, there is no state that has a stunting rate within the normal, within the accepted global level. So how do we help mothers? We need to listen to them and then talk to them. So you use helpful non-verbal communication skills. You ask them questions to know how they are feeling, give them positive responses, show interest, reflect on what the mother is saying, empathize on her, avoid using judging. I think I tell you make you breastfeed, here now you don see wetin don happen. We must keep our heads level with the mother, ensure positive facial expression. We pay attention to what she is saying, remove barriers, and take time to talk to her so that we will know what it is. And when the mother, you have found out that this is a situation of her child, we need to accept what she is saying, recognize and praise what she has done well, give her practical help, give her little relevant information, and then make one or two suggestions. If the baby is severely malnourished, we have to admit the baby. So we will say that optimal infant and young child feeding is crucial to growth and development of children, and that foods from different classes should be offered to the children to increase it as the child grows, and that maternal infant and young child nutrition training package is available. We must breastfeed the babies up to 36 months, starting with early initiation of breastfeeding, exclusively breastfeed for 6 months, and then continue breastfeeding till the child is at least 36 months. Complementary food should be started from 6 months using locally available foods, and the 10 steps to successful breastfeeding should be implemented to help us optimize breastfeeding practices. So I don't know if you have any question you would want to ask on this matter before we go on to the next lecture. Hello?
Yes,
Any
ma'am.
question?
Yes,
Good
ma'am.
evening, good evening, ma'am.
Good evening.
Please, ma'am, can you
Hello?
hear me?
Yes, I'm hearing.
Okay, thank you so much, ma'am. Please, my concern is with the breastfeeding, ma'am.
Yes.
Okay, so I have two questions, please. Number one question is, in the process of breastfeeding, there is this method of breastfeeding. So I want to be sure of it. Is it as in position of breastfeeding, is it taking the breast to the child or taking the child to the breast?
Well, when the child opens their mouth, you put the breast in the mouth of the child. The child cannot take the breast. So you give the child the breast as much as possible to make sure that the You know, the child stimulate the child. I showed you the picture.
No, sorry, ma. This is the angle I'm going. This is the angle I'm going. Like, if a mother is sitting in the position of giving the child the breast, is it the child that the mother is supposed to take the child to the breast, or is supposed to take the breast to the child?
You put the breast to the child.
Okay. Then my second question is, when you were talking about the numbers of breastfeeding, I wanted to be sure. Did you say 3 years for breastfeeding?
36 months, yes.
Okay, so if we are to cancel a breastfeeding mother with a parent, you know, considering how economics is and the tip of the child that the mother is going to give the breast milk for this period of 3 years, how are we going to handle that, man?
There is nothing, and the baby goes with the mother to the market, to everywhere she's going. That's all. Nothing. Are you laughing? Me, I breastfed my babies till 3 years. When I was going to work, I carried them to work and fed them. So there's nothing about it.
Really?
Yes.
Mama, thank you, ma.
There's
Good
nothing.
evening,
It's
Prof.
just
Okay, ma,
mindset.
I have a
You
question.
know,
Good evening,
yes, my dear.
ma. I want to ask,
I'm listening.
good evening, Prof.
Good evening.
Okay, I want to ask, what if in a situation where a mother did exclusive breastfeeding for 6 months? Evening, ma. Can you hear me, please?
Why she did exclusive breastfeeding for 6 months? Yes.
Hello?
Yes, I'm listening.
Hello?
Yes, sir, we are listening.
My question, and immediately on there is additional 2 weeks, the baby was, then at 2 weeks, like 6 months, 2 weeks, the baby stopped sucking by herself. Now, what would you advise the mother to do?
She should run 440 to the hospital so that we can help the baby to breastfeed.
Like after the mother did 6 months exclusive, then after 6 months, 2 weeks, the baby stopped sucking completely.
Mothers see other foods. That is why they are not worried. They are not worried, but if you know how important it is, suppose the child refuse to eat garri, would they say I will stay? If the child is not eating anything, sure, they will come and look for us. Now the child is not eating his food, they should come and look for us so that we know what is happening. That is all. They will come so that we'll be able to see what is happening to the child and treat the child. Okay, I know you have plenty questions on breastfeeding. I deliberately talked a lot about breastfeeding because breastfeeding protects, at least prevents 13% of under 5 deaths. So we know what it is like. Okay, so we will now go ahead and talk about.
Good evening, ma. Please, I just have one question.
Okay.
So I want to ask, please, have heard that exclusive breastfeeding makes breastfeeding mothers gain more weight. So I want to ask, is that correct? Is it scientifically based? I just want to know if that's true or it's just a myth.
No, I told you that mother's nutrition should be taken care of while breastfeeding. So the ideal thing is that a mother should eat to satisfy her hunger and drink to satisfy her thirst. There are so many courses on breastfeeding which we cannot finish talking about. I just picked a little bit of it because of the timing we have available. But in many families, the mothers will want to eat and eat until they are overfed, and because of that they get very fat. So breastfeeding does not make her too fat, but if she is to satisfy her taste, hunger, and drinks to satisfy her taste, she will not be fat, and she doesn't need so much food, during breastfeeding, because during pregnancy at least 12 kilogram body weight 12 kilogram body weight accumulated for her, so she can actually use that to breastfeed. That's why she just needs the minimum she can get to get on. But many people think that no, I must eat, I'm eating for two, I am eating for two, and because of that they are eating and becoming so fat, and not able to walk well and so on. So they should just eat just what they need to keep themselves healthy.
Thank you, ma.
Okay. Good evening, ma.
Good evening.
Okay, please, ma. My question is just for breastfeeding in HIV positive mothers. So, how
Okay.
safe is it for them after
Children,
the 6 months of exclusive breastfeeding, even when they are on medication? How safe is it for the baby?
breastfeeding, taking her antiretroviral medications, that she will be safe to take care of her baby. She will be able to breastfeed exclusively for 6 months, and then
Yeah.
continue with breastfeeding till 12 months and then stop. But if the baby is already infected, the mother can continue to breastfeed like every other woman until 2 years of age or more. But to prevent it, mothers who do that exclusive breastfeeding for 6 months and continue with breastfeeding till 1 year and stop, you then test the baby for HIV infection. Several of them have not gotten infected. Before now, they used to ask women who are HIV infected not to breastfeed. But we found out that when you tell them not to breastfeed, they tend to do mixed feeding. When in-laws are around, to please them, they will do mixed feeding. Then when in-laws are not there, um they will want to use infant formula, so they confuse themselves, and with mixed feeding the risk of HIV is higher. So instead of that, they just allow them to breastfeed like any other mother, and be able to prevent the children from getting HIV infected.
Okay, because my confusion is really on, after the 6 months, when they start introducing complementary feeds, it is still a form of mixed feeding. So is the child
by
not
that
at risk during that
by
period?
that the child's immune system has developed, and the gut has become more developed, so the risk of injury and damage that will increase the transmission of the HIV virus has reduced, so the child
All right.
can take the.
Okay. Thank you, ma'am. Thank you so much.
Okay, any more questions?
Yes, ma'am. Good evening. I have a question.
Yes.
Ma'am, please, my question is, like how many minutes are we to proceed before the baby begins to behind milk
I
and
can't
so
hear
on?
you well. Can you take it again?
How many minutes are we to breastfeed a baby before the baby begins to behind milk?
Can somebody hear her well? Who has heard her question? Is it how many weeks? We are supposed to
So I
breastfeed
say
a
like
baby.
how many minutes? No, I say like how, since the first one that comes is more of water. So like how many minutes with the baby suck the breast till it gets to behind it?
No, it's for breastfeeding. You allow the
Hmm?
child, you allow the child to feed until the child releases the breast, okay? You don't go and count 20 minutes, 30 minutes. No, you don't do that. You just feed the child as much as the child wants. When the child is satisfied, I haven't watched women breastfeed. When the baby is satisfied, the baby will release the breast and will not be looking for more. And then usually the baby releases the breast and then sleeps off. You understand? Hmm?
Ma, sometimes when you give a baby breast, I say sometimes when you give your baby breast, the baby will just suck small and remove mouth. Does it mean that the baby has gotten to be hid?
It depends on the positioning of the baby at the breast. If you do a little exercise now, you would understand it better. If you turn to the right and swallow, and turn to the left and swallow, you'll find out that when you keep your head and body straight, you will be able to swallow better. So when you keep the baby with the neck twisted to one side or the other, the baby will not be able to take as much milk as possible. So the baby will get frustrated. And then part of what you should know too is the fact that the baby reads your body language. If you are not, you are busy, hey, Nkechi, I see some people, they are paying attention to many other things. Breastfeeding is a relationship between the mother and the child. So when the mother is not paying sufficient attention to what is happening to the baby, baby will remove your breast for you. Abeg, keep your breast, I don't want it. Do you understand?
Yes, ma. Okay, ma. Thank you.
Good evening, ma.
Yes, please.
Please, ma, I have a question.
Okay.
What can be done for breastfeeding mothers that the breastfeeding is painful to the extent that they have cuts on their nipples? And what are the measures that can also be put in place even before the onset of breastfeeding to prevent such from happening?
Well, I told you people about the 10 steps to successful breastfeeding. And I told you that we need to counsel the mothers on breastfeeding and give her adequate information so that she understands what breastfeeding is all about. There is a positioning a baby needs to take to be able to suckle effectively. And if you don't put the baby in that position, the baby will not suckle well. And if the baby's neck is twisted, turn to one side and baby will not get the milk that the baby requires. And when baby gets frustrated, the baby will not continue to suckle your milk. The other thing is that when you use feeding bottles, you will not be able to get the baby to feed well, because feeding bottle affects, well, some studies have said they don't, but the general feeling is that feeding bottle causes nipple confusion. When a baby is taken from feeding bottle, the milk can come out very rapidly and the baby takes and gets satisfied, whereas if the baby is getting the milk from breast work, action, you must do some work to be able to suckle, get milk flowing. So if the baby does not suckle, then there will be a problem, and that is what we must avoid. The baby, and then you need to get the baby to suckle frequently and in good position so that the baby does not have to bite your breast. And then don't pull out the nipple from the breast. Oh, I'm tired, I want to go and check my pot on fire. You pull the nipple, because there's a tight seal between the breast, the baby's mouth and the breast. And then when you don't put the nipple well, the baby would bite you, and that will cause a lot of problem for you. And so you want to prevent that from happening by paying attention. Breastfeeding is business. You must pay attention. Don't think that, hey, abeg, I want to do it fast, baby, suck quick, make I go. No, You have to pay attention to feed the baby properly so that the baby can grow optimally. Okay. Are we fine? Hello?
Yes,
We are
Yes.
we
fine,
are
ma.
fine.
Yes, Prof, we can hear you.
So breastfeeding is very, very important, and we celebrate the World Breastfeeding Week so that we call attention to breastfeeding and the value of breastfeeding so that people will be able to use it and help women and their children to ensure optimal survival of the children. So it is something all of us have to pay attention to and ensure that we are able to manage our children effectively and reduce their risk of death. So with that, I think I'm going to get many of you becoming advocates for breastfeeding, right?
Yes, please.
Yes,
You
ma'am.
are,
Yes, Prof.
you are
Yes,
going
ma'am.
to
Yes,
help
ma.
us to
Yes, please.
promote, protect
Yes,
and
Prof.
support breastfeeding, not any little thing. You write, madam, go buy milk. Madam, this one no dey work. We need to be able to help the mothers so that they will be able to understand how to feed their children optimally and help us to help the children well. Okay, so we can now start talking about the next lecture, but I don't know why they put so many topics together, but let's see how far we can go. When we finish, I can give you, once you are tired, we will stop and I will give you the lectures to go and read. Abi? Okay, let me share. So our next topic, we are supposed to be talking about management of childhood diseases. Then we'll talk of infant welfare clinic, national program on immunization, child survival strategies, integrated management of childhood illness. You can see there are also big topics. So I will just talk as much as possible so that we get whatever remains. I can give you the full notes later. So, before we talked of infant welfare, preventing diseases in the children. Now we are talking of, we have made effort to prevent the diseases. The children have become sick. What do we do for them? How do we manage them? And so on. This is much of what we will talk about. So like I told you before that 4.9 million children died. Says you know 4.9 million children died in 2022, and that since 2020 the world has reduced the under 5 mortality rate by more than half. Even here, many children are no longer dying from diarrhea, malaria, pneumonia. A lot of we're immunizing regularly, we're doing maternal, newborn and child health week, growth monitoring activities to improve the it's almost like the population of a state dying in 1 year is still unacceptable. So we want to be able to reduce those deaths. And we noted that the first 1 month of life was very challenging, with 2.3 million children dying as newborns and 2.6 million children dying between 1 month and 59 months of age. So whatever we do, we must pay attention to that first. We must pay You must pay attention to that first 1 month of life to reduce the death of children in that first 1 month of life. And I also want you to know that between 5 years and 24 years, many children are also dying, 2.1 million. You see, we have a lot of activities for children under 5, but little is being done for children beyond 5 years. They are going to school, they are boarders, they are undergraduates, so we are not paying a lot of attention to what happens to them. And because of that, many of them are also dying. So between 2000 and 2020, say the world lost 221 million children, adolescents, and youths, with under 5s comprising 162 million, among whom were 72 million neonates and 91 million children aged 1 to 59 months. Have you seen how many deaths have occurred? And you know, when I told you that every 6 minutes a newborn was dying, and that throughout my lecture period you can calculate how many newborns have died. And it says that nearly,
But things are through that year.
hello,
Things are through that
can
year.
you please
My
mute
bad.
yourself? Hello, that nearly 53 million stillbirths have occurred, and that these stillbirths, people don't even pay attention to it. We are only talking of under
Please,
5
please,
births.
please, some people should mute their mic now. What is all this?
So if you want us to have an administrator to shut down those who are making noise, that will not be good. Okay, we can mute all. Yes, mute all current and new participants. Yes. Then when I'm ready to allow you to, can you hear me? Okay, nobody is responding now.
Yes.
We
Okay.
can
Yes,
hear you,
yes,
ma.
yes.
We can hear you, ma.
Yes,
So like,
yes.
okay. So like I told you, you know,
Yes.
53 million children died stillbirth. Some of these stillbirths deaths occur around the time of birth. The mother had been in obstructed labor in one TBA house, and then the child was born dead. Dry stillbirth, macerated stillbirth. So, but you see, the sad thing about stillbirth is people don't remember them. I don't know how many people give names to stillbirths. Children, even the first 1 week, in most cultures, naming ceremony occurs at the 8th day of life, is it not? So children from birth till 8 days don't have name. They called in the hospital baby Nkechi, baby Grace, baby this, no name. So when they say child 1, baby Nkechi, child 2, baby Nkechi, child 3, baby Nkechi. So many of those neonatal deaths, perinatal deaths, early neonatal deaths, they don't have names, and people tend to forget them. So it is calling your attention to these situations so that we can work on them to improve what happens to the children. Okay, so the world has made substantial progress, reducing under 5 days by about 50%, but still many are dying. And that is why the Sustainable Development Goals wants to see how they can reduce these deaths. And they noted that 64 countries are not on track to reducing neonatal deaths, and 54 countries are not on track to reducing under 5 days to achieve the Sustainable Development Goals, with Sub-Saharan Africa being one of the most affected, that currently records 27 neonatal deaths per 1,000 live births, followed by Central and Southern Asia that records 21 neonatal deaths per 1,000 live births. And we remember we're supposed to go to 12 per 1,000 live births. So all of us have to sit up and start working, because Nigeria is a country with the highest deaths, Then that globally, you should know that 25% of the population is under 15 years of age. So whatever effort we put in to address deaths in children will be very, very important. I know Nigeria has a pyramidal shaped population structure, with almost 50% of the population being in children between 0 to 18 years. So you can see it here. 41% 0 to 14 years, and that our under 5 mortality rate is around 110 per 1,000 live births, neonatal mortality 41 per 1,000 live births, and infant mortality 63. So we need to invest at local, subnational and national levels to be able to reduce these deaths you are talking about. So one of the ways the government has invested is to embrace primary healthcare. We have healthcare at 3 levels: the primary, secondary and tertiary. And at the inception of primary healthcare, WHO accepted 3 components: health promotion, promotion of food supply and proper nutrition, adequate supply of safe water and basic sanitation, maternal and child healthcare services, including family planning. And that is where we are anchoring our lecture. But primary healthcare has now grown, and several of the components have been separated. So we now talk about immunization, prevention of locally endemic diseases, in treatment of common illnesses, provision of essential medicines and supplies, promotion of program on mental health and oral. So in addition to those initial 4, we have this additional one. So we now have 10 components of primary healthcare, and different countries add what they want to ensure that they attain the goal of optimal health for their children. Now look at this prevention of locally endemic diseases. I showed you the causes of death in children under 5, that malaria, diarrhea and respiratory infections were the common causes. So in adapting our primary healthcare, these common diseases which occur in our environment have been targeted: malaria, dysentery, respiratory infection, polio, measles, pertussis, HIV, yellow fever, cholera and other things have been targeted to ensure that we prevent them as part of the control of common locally endemic diseases. And we have the control of diarrheal disease program, the HAD, control of diarrheal disease program, management of acute respiratory infection, but malaria control program. These 3 programs have now come under the umbrella of the integrated management of childhood illness. Some part of tuberculosis and leprosy control program have also come under, but because tuberculosis and leprosy affect mainly more of older people, even though they occur in children, the TB leprosy program, onchocerciasis, guinea worm, HIV are still being run as parallel programs, but under the umbrella of the primary healthcare. Then when we talk of maternal and child health services, we talk of pre-pregnancy, pregnancy and post-pregnancy services, because when these are not properly done, our children's lives are affected, and we need to optimize what happens in pregnancy and during delivery, so that the women will deliver safe and healthy babies that will enter into the child healthcare program. So primary healthcare service provide care for children till they attain the age of 18 years. That is the age of children. But in our environment, some children by 15 to 18 years are married or mothers. But ideally, up to 18 years, they are still children and covered under the services for children. So the primary healthcare system cares for newborns, under 5, the school-age child and the adolescent. So this is the big umbrella under which the integrated management of childhood illness operates: immunization program, breastfeeding and other activities they operate and ensure health is provided. Then we also do education at the health education to identify the needs of areas of needs for which we target health education interventions, like where there is sexually transmitted infection among the youth, you can target youth activities to help them to reduce the risk. Where there is an immunization problem, you mobilize them at the community level, give education and communication, develop appropriate learning materials, and monitor the achievements of what you are doing. At the state level, we need to train people, promote routine health promotion through radios, televisions, demonstrations, cleaning the environment, and involving specific programs to improve the health of the children. We also need water and sanitation, safe water. I told you a child needs 100 ml of water per kilogram body weight in the first year of life, first 10 kg. So we need safe water. If we don't have, I told you 70% of children do not have the water they need. So we need safe water. We need to protect the sources of water and monitor the quality. Some waters that we get have an E. coli in it, and then we resort to pure water, bottled water, which many people cannot afford. But we need to monitor the quality of water. Before, we used to have central water supply, but now almost every family has their own borehole to drink water from, which makes it difficult to monitor it centrally and promote people. Then we need to talk of promotion of personal hygiene and environmental hygiene. And I'm sure you know how our environment is. Then issue of housing is also a problem, because all these impact on the survival of children, and we need to help the children. We need to also be able to treat the children. It's part of the primary health care, treating children for different injuries, and this is where the primary health care services targeting children, training them for IMCI. They have the community health practitioners, where there is no doctor, but we want to have skilled health workers to provide the services, diagnose the diseases, and they do not need to rely only on symptoms, but they must be able to combine the diagnosis to provide them treatment. Then the essential medicines and supplies. We need to be able to procure and supply essential medicine. Different, the national level, we have the essential medicine list. World Health Organization also has its own essential medicine list. In Rivers State, we have the essential medicine list, so that you don't go and buy medicines that will not be useful for people. Buy the medicine that will address the needs of majority of the people based on the common illnesses they have in those communities. So those things like anti-cancer medicine, meropenem, ceftriaxone, those heavy medication should be reserved for the higher levels of care. But I know now even chemists will go and give injection meropenem, which is not correct. We must rationally prescribe the medicine and distribute them, engage in health promotional activities to minimize the wrong use of antibiotics and medicines. Sometimes somebody has cough and catarrh, give meropenem, give Zinat. People are using antibiotics inappropriately and leading to increase in the burden of antibiotic resistance. We need to educate people about the use of medicines, care seeking, and finishing the medicine. I'm sure some of us, if we start malaria medication, some we don't do test. Oh, I'm feeling headache. Oh, I'm feeling feverish. We go and take anti-malarials, and then once you take it for 2 days and you feel better, you stop it. Even your children used to forget. So we need to understand. We need to give the skill, appropriate storage and retrieval of essential medicine. We must label the medicine well, communicate effectively. So the other components include them. Like different things different countries want to add, but Nigeria added the promotion of oral and dental health, mental health, care
Mhm.
for non-communicable diseases, and care for the elderly and the handicapped. So these are different things that primary health care do. So the integrated management of childhood illness we are going to talk about operates within the umbrella of primary health care. Sorry. So what are the child survival strategies? We have a lot of indices that show what the child survival is. I've told you how many children are dying and what are they dying from. So these child survival strategies are the things we can do to reduce these deaths, and they reveal that some of the deaths occur because of violence, because of war, because of neglect, emergencies, disasters, and that the Sustainable Development Goals wants to be sure that we will improve child survival by 2030 by reducing additional 10 million the number of children who would have died between 2017 and 2030, and that half of them will be newborn. So if you apply these strategies we are talking about, we will be able to save about 10 million children. You see how many million I told you died. So we need to reduce those deaths. So the survival strategies are simple things we can apply to reduce the death of children. It was started in the 1980s by UNICEF and WHO, and they called it the GOBI, acronym the GOBI, which stands for growth monitoring and promotion, oral rehydration therapy, breastfeeding and immunization strategies. So it has continued to evolve and include newer strategies to address current and evolving challenges to child survival, but they remain crucial to reducing child death and attaining global development goals. So different regions decide what will be their own strategy they want to adopt, and that when we don't achieve targets we roll it over. Like when we have the Millennium Development Goals, as we didn't achieve it we rolled it over to the Sustainable Development Goal period. So the currently recommended child survival strategies by UNICEF, which many people are using, have been acronymed the GOBIFEP, which stands for growth monitoring and promotion, oral rehydration therapy, breastfeeding and proper weaning, immunization, female, so that will be breastfeeding and complementary feeding, female education, family planning, food supplementation, it should be essential medicines and supply, environmental sanitation and protection, treatment of common injuries and the ailments, and health education. So these strategies are the things we are talking about. It's part of what you're supposed to know. How do we employ these strategies to optimize the survival of children? But to see how important they are, you can see that, like I told you, that breastfeeding alone will reduce 13% of under 5 days. Then we talk of insecticide treated net, complementary feeding, use of zinc, clean delivery, immunization, water and sanitation, antenatal steroids, newborn care temperature measurement, vitamin A, tetanus toxoid immunization, nevirapine, use of antibiotics, and measles vaccination. So you can see that combining them will give us the whole. But if you just focus on one, you will still have deaths occurring because you have not applied these other strategies. So you must try to see how to put them together with attention to the ones that have the greatest impact. Now, looking at the immunization, which is part of our lecture today, you can see that immunization is to prevent many of the vaccine preventable diseases like tetanus, measles, Haemophilus influenza, rubella. So the countries adapt their immunization schedule to reflect what they need. Recently, this year, the Nigerian government changed their immunization schedule. Now, if you are confident with the immunization schedule, BCG, camel berry, and oral polio vaccine, hepatitis B vaccine at birth. But you know, 1% should be able to go back to the hospital and have im vaccines. The route of administration have been specified. BCG should be given intradermally, oral polio vaccine should be given orally, hepatitis B vaccine at best should be given weeks and 14 have been introduced. The pentavalent vaccine repeated. Then pneumococcal conjugate vaccine, oral polio vaccine, rotavirus and inactivated polio vaccine. That is at 6 weeks, and those routes are oral, intramuscular and oral. Now these vaccines will address several of those diseases I showed you that contribute to under 5 mortality and morbidity in our environment. Pentavalent vaccine contains 5 vaccines. Diphtheria, recently we had an outbreak of diphtheria. In fact, in teaching hospital in Port Harcourt, and in some states, some children died from diphtheria, but they had to improve the immunization coverage to contain it. We also know the menace of pertussis, a disease that children will cough with and bleed into the eyes. They will convulse and other things. Then tetanus. Tetanus used to be a big problem. By 1995, neonatal tetanus was supposed to have been eliminated, but it continues. Only in the last 2 years we have not been seeing, because several activities are targeting pregnant women to immunize them and improve vaccine coverage. But we still have hepatitis B. Many people are having hepatitis subclinical level and are having the virus damaging the liver and contributing to cancer of the liver with a primary liver cell carcinoma and then hepatic cirrhosis. Then we have a pneumococcal vaccine, pneumococcal conjugate vaccine, which is to protect against pneumococcal diseases, streptococcus pneumonia, which can cause throat infection, lung infection, pneumonia, bronchopneumonia, and can also cause meningitis. So we start giving the children at 6 weeks. We've been fighting against polio paralysis with the use of oral polio vaccine. At least we have been able to contain the menace of polio, but we must sustain the immunization. Otherwise, with the prevalent environment we have, we may still have a resurgence of polio. The rotavirus vaccine has been introduced to address diarrhea. Like I told you, malaria, diarrhea, pneumonia are the 3 common causes of death among our children. So the rotavirus is to address it, while oral polio vaccine and inactivated polio vaccine are to address the paralysis caused by poliomyelitis infection. So these vaccines are given at 6 weeks, 10 weeks and 14 weeks for the children. Then recently at 5 months, the malaria vaccine was introduced, because I showed you that malaria was one of the common causes of death, and that studies have shown that between 0 and 5 months, maternal antibodies against malaria are high. So if you give the child the malaria vaccine, it won't work. So by 5 months, the antibody level begins to wane. So we have to immunize the children with malaria vaccine. It is given at 5 months. It is also given at how many days? 5 months, 6 months, 7 months, and 15 months. Then at 6 months, we give vitamin A, but it is not a vaccine. But because we have tagged it to the immunization schedule, we give it. It is not a vaccine, but you just note that they give it every 6 months, because I showed you the level of vitamin A reduces for the breastfed child. So we need to augment it, whereas vitamin C level is still very high, 95%. Vitamin A reduces to about 45%. So we have to give vitamin A supplementation from 6 months to augment the level in the child to protect the child against vitamin A deficiency diseases. Then at 9 months, we now give measles rubella vaccine first dose and repeat it at 15 months. Currently, Rivers State has not started, but some other states have started the measles rubella vaccine. Our own will be flagged off in February this year. Some states have started because measles we are containing the menace is not as common as it used to be, but we have to keep the vaccination on because measles can occur rapidly and kill several people. The rubella infection does not kill like measles, but it damages the brain of the child, the heart of the child, the eyes of the child, and therefore it is a significant risk with congenital rubella syndrome. So that vaccine has been brought on board, and we are hoping that they also bring on board the mumps vaccine because many people also have mumps, mumps virus infection, because in advanced countries you have mumps, measles, mumps, rubella vaccine. So we need to continue to advocate for the inclusion of mumps vaccine into the schedule. At 9 months, we have yellow fever vaccine. Luckily, yellow fever, well, in the Delta area and some parts of Africa, we have the yellow fever receptive zone, yellow fever endemic areas where Aedes aegypti transmits the virus and people get infected. It's a form of hemorrhagic fever, and so we have to get immunized against yellow fever. Luckily, once you are immunized, you only need to repeat it every 10 years to remain protected against yellow fever. Then we have the meningitis vaccine, Neisseria meningitis. We are in the meningitis belt, but it's commoner in the north. However, because of the free travel between the north and the south, and the meningitis due to Neisseria meningitis can also occur in the southern parts, but in the northern part, it can occur in epidemic form, especially during the Harmattan season, where people tend to stay close because of the cold. So Neisseria meningitis is a very important effective agent that must be contained. But you should note that meningitis can also be caused by Streptococcus pneumonia and other organisms. So when we immunize the children, we are able to protect them against these vaccines. Then at 9 months, 9 years, we remember to immunize the girls against human papilloma virus vaccine to protect them against infection with human papilloma virus, which is known to be a precursor to cervical cancer. Why are we targeting children at 9 years? We are targeting them because they have not been sexually exposed. Human papilloma virus is a sexually transmitted disease, and it not only causes cancer of the cervix, it also causes cancer of the nasopharynx, and it causes warts, venereal warts, and other forms of warts. But because of the significant number of cervical cancer it causes and the number of deaths it causes, it has been input into the national immunization schedule to protect children from 9 years of age. So the older women who have not been immunized need to be tested to know, they need to do the pap smear to know whether they are infected already, early signs of cervical cancer, and those who are infected should be treated. These are the policies the WHO has adopted to be able to contain the menace of human papilloma virus infection. Then for women of childbearing age, we need to protect them against tetanus by giving them 5 doses of tetanus toxoid intramuscularly starting from the first contact, which is during the first pregnancy, then 4 weeks after, 6 weeks, 6 months after, and then each year during the subsequent pregnancies to ensure that they receive 5 doses to give them lifelong protection. And when they receive these 5 doses, they also protect their children against neonatal tetanus. So the immunizing women with tetanus toxoid protects them and protects their children. But if you know the vaccine that we are showing you now, it is capital T and small d. So the vaccine that is currently being used contains the tetanus toxoid and the diphtheria toxoid. So this has replaced the tetanus toxoid alone. It is now tetanus diphtheria toxoid that we are offering mothers. So please note it is TD, not TT. So that is the vaccine. So this is the immunization schedule that we need to use to immunize our children. This is the full national schedule for children between 0 and 36 months, so that when they are accessing the immunization coverage depends on the age of the child. But as much as possible, as part of our child survival strategies, we must check to ensure that the children are immunized up to date, so that those who have not been immunized, we pick them out and immunize them. Now, when the child survival strategies came out, they wanted to accelerate the attainment to reduce under 5 days by 2015, reduce maternal mortality, and reduce under 5 malnutrition, because then efforts were being made to achieve the Millennium Development Goals. But now that the Millennium Development Goals have passed, we are also talking of accelerated child survival interventions to attain the Sustainable Development Goals, and I will discuss it later. So the activities then are still relevant today. That is why I have brought them on board. The Accelerated Child Survival and Development Program. We are talking of immunization, the routine immunization and periodic measles catch-up and mop-up. We still do this. When there is an outbreak of measles anywhere, we go and mobilize or immunize all the children that are in that region. We also give vitamin A supplementation to children twice yearly, promote and distribute insecticide treated nets for children and pregnant women, and then redeem the net. That time we had to redeem the net, but now we are using long-lasting insecticide treated net, so we don't need to redeem it, but the mosquitoes must be prevented from biting the children through the use of insecticide treated nets. Then we talk of antenatal care plus. We must give the women intermittent preventive treatment of malaria with sulfadoxine pyrimethamine for pregnant women. Initially it used to be 2 doses, but you know now we have increased the number of doses, so the women get it at almost from 3 months every contact, so that they can be protected against malaria. Then we give them tetanus containing vaccines to prevent maternal and neonatal tetanus. Then we also supplement the women with iron and folic acid during pregnancy and postpartum, and deworm the women so that the worm burden will be removed. Then we improve the management of pneumonia, malaria and diarrhea. I told you these are the 3 common causes of death among children under 5, and we do that by promoting exclusive breastfeeding and timely complementary feeding. That means you exclusive breastfeed for 6 months and continue the other foods in breastfeeding till 36 months. We want to improve and integrate the management of childhood illness at the health facility, community and community level. So at the facility we have integrated case management of childhood illness. We also have integrated community case management for pneumonia, malaria and diarrheal diseases at the community level. So community health ex ten sion workers are taught to go and manage it. And we also have the community IMCI component, which is to improve the health practices at the community and family level to reduce the risk of death and ensure that children have opportunity to live well. We also talk of promoting the use of iodized salt at the household level. I'm sure you still see people with goiter in our communities. Some are now getting thyrotoxin, but some have hypothyroidism from goiter, from deficiency of iodine. So we need to promote the use of iodized salts, and those who have goiter should be investigated so that if they have thyrotoxicosis, they can be managed. Those who have low level of iodine will also be managed and treated. Some will need surgery to reduce the size of the thyroid gland. So Nigerian government adopted this accelerated strategy by looking at newborn care. We told you that a lot of children die in the newborn period. So we adopted the essential newborn care. The Nigerian government has its own component of essential newborn care. Now we are even monitoring and doing the maternal, newborn and child death, perinatal death surveillance and reporting to see what is causing the death in the newborns, where are those deaths occurring, and how can we reduce it. Then we talk of infant and young child feeding, including micronutrient supplementation and deworming. So we promote breastfeeding. We just talked about breastfeeding. We also promote micronutrient supplementation, giving them vitamin A, folic acid, and zinc, using zinc for diarrhea cases, and then we deworm the children to reduce the burden of worm load and reduce the iron losses through worm infestation and the micronutrient nutritional losses. Then we give mothers immunization and give my children immunization. We've talked of tetanus, diphtheria, toxoid for the women, and then the newer vaccines we have introduced for the children, including the malaria vaccine, rotavirus vaccine, inactivated polio vaccine, and
I'm not listening to what you're doing again.
pneumococcal vaccines. So we are promoting the use of those vaccines for children. So the immunization schedule will keep being changed. Now in Rivers State, we start adding
Go to
measles and
live
rubella
Moses.
Right now, right, Moses?
vaccine. Then we talk of prevention of mother to child transmission of HIV, but now we are talking of elimination of mother to child transmission. We discussed about HIV infected women and how they should feed their children. Now they are giving them highly active antiretroviral medications. During pregnancy, they will test, and for us, every child that comes, we have the provider initiated counseling and testing. You counsel, you test, and those who are positive, you send them to the HIV unit for continuous monitoring treatment. They will treat a mother who is put her on highly active antiretroviral treatment, and then you put the baby on nevirapine, you breastfeed the baby, then you test dry blood smear, test the baby at 6 weeks, and then monitor the child to ensure that the child is growing, and if there are signs of infection, the child should be treated. And they also give them cotrimoxazole to protect them against infection from during this period of increased risk. Then we talk of preventing malaria using insecticide treated nets and intermittent preventive treatment of malaria. In some parts of the country, they are treating children under 5 with anti-malarials, but in some other parts, we have not adopted that strategy. Then we talk of management of common childhood illnesses, and then severe acute malnutrition. You know, if you pay attention to your communities, you will see some children have community case management of malnutrition, severe acute malnutrition. There is CMAM centers. They have such centers where malnourished children who do not need admission are treated with ready-to-use therapeutic food. Then the other ones who are severely ill are managed in the hospital. Then we have the integrated management of childhood illness, where the health workers are trained to use the combined skill of assessing the children to optimally manage them with the strategy which has been adopted since the 1995-97. Then we talk of management and care of HIV exposed or infected children. They have to be cared for. They should not be segregated against. So then the UNICEF also had its own strategy they called the Unite for Children. The goal was to engage all relevant actors in the community, nationally and around the world, to unite to deliver the best possible results for children. So it is still several of the activities, that is accelerating scaling up of well-defined evidence-based integrated package of low-cost, high-impact child survival interventions. For example, breastfeeding. The mother does not pay for it, but it is helpful. Keeping the environment clean, washing hands, disposing feces safely, giving the child clean water, breastfeeding exclusively, complementing the breastfeeding with appropriate. So UNICEF wants many more people to use this. You have to improve communication with families and communities for improved health and nutrition practices. That's why we're doing like World Breastfeeding Week. During maternal, newborn and child health, you mobilize the people, you talk to them. Then we strengthen the capacity of health workers for routine services, immunization service. They regularly train them. We train them on breastfeeding. We are training the health workers to ensure they can deliver quality health care for our people. Then there used to be child health days where we integrate the delivery of immunization with other health and nutrition interventions such as vitamin A, deworming, growth monitoring, and distribution of insecticide treated nets. UNICEF used to have those child health days, but now we have the maternal, newborn, and child health week to reach out the people. Then African heads of state were also concerned about child survival. So on the 4th of in July 2005, they declared that they, the heads of state and governments meeting at their 5th Ordinary Assembly in African Union in Libya, pledged and resolved to commit their political capital towards improving on child survival in Africa and using our national resources and with the support of international community to reduce the annual number of child deaths occurring in Africa by 1.5 million by 2010 in order to achieve the Millennium Development Goal by 2015. I'm sure you know it that we did not achieve that goal. The African leaders agreed they will commit 15% of their income of their budget to health. But you know, even in Nigeria, we've never had 10%. So the leaders have not met up to their expectations, but they have engaged in many activities to improve the survival of children. But like I showed you, most of the deaths in under 5 still occur in sub-Saharan Africa. But they had guiding principles to use to improve the survival of children. They wanted a life course approach where you optimize them, you promote optimal growth and development of the child from the uterus across to 0 to 5 years age group to prepare each individual for a healthy, well-adjusted, productive adult life through coordinated implementation with other strategies aimed at achieving the Millennium Development Goals and protecting health. And like I told you, when the MDGs were not achieved, they were rolled over to the Sustainable Growth Period. So this is still on in the African region. They also wanted equity. When I showed you the slides on the distribution of nutritional status, immunization coverage, antenatal coverage, I showed you that people in the rural areas were disadvantaged. They did not access quality services like those in the urban areas. So the equity, on the platform of equity, they wanted to be sure that there would be equal access to child survival interventions for all children. That is why every local government is involved in immunization activities. People go to cover all over, they monitor them to ensure that even children in the remotest areas are reached. That's why children in the war-torn northern part of Nigeria are also reached with immunization services. Then it should be rights-based. Child's rights-based planning will be incorporated in child health interventions to ensure the protection of the most vulnerable. Like I told you, nutrition was part of the child's right document, immunization, health care seeking. I will send you the Convention on the Rights of the Child and the Nigerian Child's Rights the document. So you will see that using the child's right base as a platform, every child is entitled to care, to protection, to optimal nutrition, to early diagnosis and treatment. And recently in Nigeria, they are talking of a basic healthcare provision fund, because we know that lack of fund obstructs care delivery. And then they've also talked of a emergency, emergency care for children, emergency care for pregnant women. So child's right base makes sure that every child can access quality care as a right. Then integration, that efforts will be integrated so that as much as possible with one stone we can kill many birds. Integrating the care. So before I told you there were parallel programs, malaria control, diarrhea control, acute respiratory infection, but all these have now been merged into the integrated management of childhood illness. And under that childhood illness, we also talk about immunization, breastfeeding, HIV, and so on. So these are being put together to ensure that with minimal resources we can work well to achieve our goal. Then they talk of multi-sectoral collaboration. So health issues are developmental. So to achieve health outcomes, you must have other people collaborate, as was defined in the primary healthcare document at Alma Ata. So the people in water, in sanitation, in water and sanitation, people in security services, NIMA, those on protecting us against flood, giving the warning sign, the security agencies, educational people, health sector, all these groups must work, including the agricultural sector, so that the collaboration will help us attain optimal health for the children. Then partnerships, the hospital cannot do alone, the government cannot do it alone. So we need several other partners from industries, academia, community and co to work together to deliver healthcare. So the African Union recognized they could not do everything at the same time. So they talked of essential packaging of services. That's why you have the essential newborn care, those things that must be done to help the people. They had a roadmap. They will promote a lot of services for the newborn and prevention of mother to child care. They talked of IMCI, Integrated Management of Childhood Illness, newborn care services, ensuring access to skill care, the optimal newborn care services, treating the cord with chlorhexidine gel, promoting care seeking in the newborn, and the Making Pregnancy Safer initiative, which has expanded to include care for the newborns. Then we talked about feeding the children, infant and young child feeding, including micronutrient supplementation and deworming, giving vitamin A, iron and iodized salt. Then we prevent malnutrition, and those who are malnourished, we take care of them early so that it will go. Then we prevent malaria and treat those who are infected. We distributed insecticide treated nets and artemisinin-based combination therapy in this country. So use of artesunate injection became easier. Before now, artesunate used to cost almost like 3,000, 4,000 a vial. So mothers could not buy it. But now the price has come down and more people can get it. Then it included the immunization of the mothers giving them tetanus toxoid, childhood immunization through outreach and fixed facilities, prevention of mother-to-child transmission of HIV, management of common illnesses with ORS and zinc for diarrhea, a proper antibiotic use for pneumonia, dysentery and neonatal infections, and prompt and effective treatment of malaria at health facility and community levels. Then children who are exposed and HIV infected were to be treated, and IMCI was to be the umbrella for those services. So those child survival strategies in the African state, they chose all those high impact, cost effective interventions and put them together, summarize them as skill care at birth and quality emergency obstetric and newborn care. I think you have seen the CMOC, that emergency obstetric and newborn care, management of preterm birth, including antenatal corticosteroids for lung maturation, basic neonatal care, including neonatal resuscitation. I'm sure you know they are training a lot of people on neonatal resuscitation. Then early identification and antibiotic treatment of serious infections, inpatient care for small and sick newborns, and prevention of mother-to-child HIV transmission. Then integrating these services into the where the high impact ones they wanted to be used for reducing neonatal deaths. And like I told you, neonatal deaths have to be reduced if we must achieve the sustainable development goals. Then, if there is unmet need for family planning, because many, so we must provide family for abortion will decline significantly. Then we need to provide full range of contraceptive services for women with HIV so that fewer of them will get pregnant where they don't need to get pregnant. Then they looked at other long-term things, improving the education of women, encouraging their work, making sure they have money, because part of what used to cause women to be at risk is that they don't have money. They are not employed. In their house, they earn little, so they are subjected to denial of their rights. So that the government services, that they are cost effective, save lives, and are the cornerstones of sustainable development. But you know, since the Trump government came and withdrew their support, many family planning services are no more running as effectively as they used to. So that initiative has to be looked at. So we need to advocate to harmonize the strategy and need to formulate and implement the strategies. We also need to mobilize resources at the family levels, at the population level, at the individual levels. People need to know what they can do for themselves. We need to train more health workers and we need to retain them so that they can help us. But since the government saw they couldn't do it well, they talked of the minimum package of care, exclusive and breastfeeding, neonatal care, immunization, deworming, vitamin A. These are packages I had talked to you about. So they want that to be a minimum package. Then they talked of an expanded package where you have the minimum package with other things, which included the expanded neonatal care, Haemophilus influenza vaccine, and emergency obstetric care. And I'm sure some of you know that the emergency package is being implemented where mothers who and receive care. Then the maximum care includes giving a mother the full range of care that she needs, and the responsibilities for ensuring child survival lies at the country level. They must have policy, They must develop capacity, they must provide resources. At the community level, stakeholders must do things to help us, those who are doing things. Before, we used to depend on the United States funding, but we must begin to look for people within our systems to provide funds for us. We must also engage in research. Soon after now, people are going to do research, but look at research that will help us know our areas of priorities and what to do. We need to document our challenges, our successes, and then monitor our activities. So we've talked of the roles of government: provide and subsidize vaccines, build capacity for health workers, provide funds for use in the healthcare sector, subsidize for food fortification by giving vitamin A, iodized salt, zinc, and so on. No, we must provide healthcare infrastructure and deploy health workers to serve in the community or general public. Yes. Then we must create awareness through flag off. So some people will say, oh, why are we doing what breastfeeding with? Why are we flagging off it? Because we are creating awareness to mobilize people to seek for those services. So all the other stakeholders must also join in the advocacy, provide technical support countries to identify and document best practices, and support countries to develop the capacity for research and facilitate coordination and collaboration. The mothers have a role to play. They must be ready to go to hospitals, breastfeed their children, optimally feed their children. They must go to school, learn to learn, use family planning services, seek for care early, and comply with the treatment. The health workers also have a role to play by being available, identifying women, offering them proper services, teaching them health education, facilitating births, emergency preparedness, ensuring that they are equipped for vaccination, dispensing micronutrients, and treating the children, monitoring growth. I showed you the growth card, child health card of a child. The health workers just write the weight on the chart. It is supposed to be plotted, so you will see whether it is going up, it is flat, or it's going down. Then we must promote breastfeeding, family planning, and optimal infant and young child nutrition. Because the world is concerned, they develop the strategy, global strategy for women's, children's, and adolescent health. To end by 2030. That's about 5 years. Contains a comprehensive package of services for mothers, women, and children, and it helps to strengthen the health system, health workforce capacity development, and coordinated research. So you can see that the strategies are crisscrossing, and then because in Nigeria's zone, they had to pick a certain number of strategies. We've talked about all this on exclusive breastfeeding, immunization, ORS, treatment of diseases, micronutrient, access to ready-to-use therapeutic food, scaling up high-impact intervention, and other things. We've talked about them many times, and so we need to know what they are. But for the Nigerian government, the National Health Policy 2016, the National Child Health Policy, and the National Policy on Health and Development of Adolescents and Young People, National Strategy on Reproductive, Maternal and Newborn Health. Then we now have the Child Survival Action Plan. Several national documents and policies have been developed, but our problems have always been on board. Should identify these policies and see how you can help us to implement them. And some of them include the National Maternal and Newborn Health Quality of Care Service, National Pneumonia Control Strategy, National Essential Medicine List, National Policy and Strategic Framework for Community Health, Accelerated Reduction of Maternal, Newborn, and Child Mortality, Community Health Influencers Program, National Guidelines on Basic Newborn Care, National Guidelines. So the guidelines You can see several of them. Now, the RAMCA has also been introduced as a basis of activity for this government. It is government-led, multi-sectoral, quality-focused, integrated, efficient, gender-based, innovative approaches, primary healthcare as a bedrock, and it is people-centered. That is the RAMCA strategy. Initially, it was RAMCA plus nutrition, but now they have created a separate department of nutrition. The vision is to make sure that all women, all Nigerians, especially pregnant women, children and adolescents, and women of reproductive age, and the elderly have universal access to quality and comprehensive healthcare services and optimal well-being. The mission is to promote integration of reproductive, maternal, child health, and adolescent services and programs along the continuum of care, and provide a framework for the equitable delivery of high quality integrated care across a life course. So you hear this swap technology, swap approach, but the RAMCA is the basis for the health sector one. So for the newborn who are our own, the objective is to end preventable stillbirth and newborn deaths, reduce morbidity and mortality from major causes of under 5 days, prevent child vulnerability, and ensure vulnerable children survive, thrive, and transform to reach their po ten tials. So it brought a hard target to reduce stillbirth rate from 22.5% to 19% by 2018, to reduce perinatal mortality, that's stillbirth and early neonatal death, from 49 per thousand live births to 22.5 per thousand live births, to reduce neonatal mortality from 38, now we have it as 41. When RAMCA was adopted, it was 38, now it's 41. We are supposed to reduce it to 17. And you know, the sustainable development goals say we should reduce it to 12. So you can see where we are. Instead of reducing, we are increasing. Then the several targets for newborn and child health: reduce under 5 days, increase reduce low birth weight, increase immunization and other things. The RAMCA has like 30 indicators, so it is to guide the activities for Nigeria. Part of the way have been survival of Nigerian children, maternal, newborn and child health. Use of funds can prevent it. I'm sure some of you have heard about it, that it is an approach and interventions for the maternal, newborn and child health, and was approved in 2010.
We
So
end
from
this
20
lecture, please.
it is being held, will soon end. So it has been adopted by all states and people are running with it to increase services to women, life-saving preventive services, not for treatment. They go to reduce maternal, neonatal and child mortality, morbidity and mortality. Is done twice annually for a duration of 5 days, and they are given in health facilities, but sometimes they go out to vitamin A supplementation, deworming, immunization, distribution of mosquito nets, distribution of vitamin folic acid and iron, sulfadoxine pyrimethamine for pregnant women, family planning commodities, testing for HIV, treating for diarrhea and birth registration. So the whole essence is that there are routine services, and then through the campaign we now strengthen the health for services for women and their children through these interventions you have seen. And it has helped. The targets are there, which I would not want to bore you with, but it is summarized as a simple one-off approach to delivery of a combination of services that immediately demonstrates impact in terms of significantly increasing coverage levels of all core preventive and curative interventions that allow mother and child to thrive through existing health services. So they are providing those child survival strategies, insufficient fund, low level of participation, low health work expenditure, poor documentation, and so on. So they to help us achieve the goals, improve the African government and so on. Nigeria, they now talk of child survival action plan for 54 countries. I told you that 42 of them are in Africa that still have under-5 mortality rate above 25 per thousand live births, because that is where we reach. So it is reaching the children that are being efficient partnership and mobilize required resources. So these are the 54 countries. You can see that majority of them are in sub-Saharan Africa, with Nigeria being a very important member of those people. And these are the leading causes of them, which we have talked about: diarrhea, pneumonia, and other diseases in the children in those 54 countries. And Nigeria is at the base. Here, this is Nigeria, just second only to Chad. So we have a lot of work to do, and that survival of children between 1 to 59 months is critical. We have to talk about them. And the reason why they are dying is because those high impact interventions we have talked about are not reaching the children. See, diarrhea, the malaria, and other things, they are not getting it, and they are not being treated well. So we need to accelerate it, monitor the growth of the children, boys and girls, know that they are growing optimally, and then use the integrated management of childhood illness to treat them. The IMCI, which is a short, addresses the major causes of death in places. They can adapt it, but it has added HIV, maternal health, expanded to include newborn. Originally, it was for respiratory infections, diarrhea, measles, and malaria, and malnutrition. So it is to improve the performance of the health worker, improve the health system, and family and community practices. It has guidelines that people are using. It is a scientifically based, evidence-based, and effective in its implementation. From 1996, it is being applied in over 400 countries now. Nigeria of childhood illness, simply because many children are dying, and the health workers need to be prepared to assess children who have multiple presentations and manage them in an integrated manner, and be able to talk to the women. And it is providing skills that health workers at the first level can use to manage the children easily. When it is implemented very well, there will be availability of medicines, organization of health services, the referral pathways must work, the communities must behave well, be able to support the care, and it is important that we integrate the strategies. So the globally, the 4 major killers of diseases, diarrhea, pneumonia, prematurity, and are covered in the IMCI strategy with malnutrition. So we are carrying them along, and we have continued to need it even beyond the sustainable development goals, because so many of our children are dying. To introduce IMCI in any country, they have the introduction phase. Many countries are doing so. You go to talk to them, look at what the disease patterns are, and decide that, oh, the children, more than 40 children are dying per thousand live births in the first 5 years of life, like Nigeria that has 110 deaths per thousand. So you need IMCI. Then you test it in a limited number of areas in the early implementation phase. If the people see how it works and they gain experience, they now go to the expansion phase. Nigeria is currently in the expansion phase. Many states are adopting the IMCI strategy and are using it, expanding in the scope and the number of services offered and the community. So in health workers are being trained across African region. But from 2004, the number of people trained have continued to increase even in Nigeria. But the important thing is that unless you train at least 60% of the health workers in a particular area, you cannot cover the place effectively with IMC because some will be off duty and others may not be there. So we need to train people so that around the clock they will come. Initially, IMCI used to be 11-day course. Now it has been reduced to 6-day training program. Some also are integrating it into the ongoing training of health workers. So in the School of Nursing program, School of Community Health Officers program, and Medical Students program, we have some part of IMCI introduced so that they are sensitized to ensure that people understand it. Nigeria has introduced it since 1997, developed guidelines. In fact, recently we updated the guideline for IMCI to include like something like pulse oximeter, which was not there before. We have integrated it. We have reviewed the treatment modalities, the referral pathway. So we are increasing the use of IMCI. About 32 states and FCT are implementing it, but the problem is that it is fragmented. Maybe some local government to train one or two people, like the last training we had, we trained about two people or so from the different local government areas, and that is not enough to deliver IMCI strategy in our state. In some of the states, partners have trained several people like Ebonyi State and in the northern states. So we need many more people to be trained to build reasonable capacity. Now, IMCI has three components: improving the skills of the health workers through the clinical skills training program I have talked about. But when the health workers are here, have the skill, the health system must be improved. We have to provide medications, weighing scales, simple tests, organize the work and other things. Other health workers must be there so that we can be able to deliver on the services. Then the community must improve their family and community practices. They must be able to seek for care, accept the treatment and work together. So all these three components have to work together for effective implementation of IMC, and this is how it works. In improving, you must do adequate nutrition, home case management. When children are sick, come to hospital and you prescribe treatment for the child. The village people should say, no, not be like that we dey treat our children. Na like this you want. The children must be treated well at the home. They must adhere to the recommended treatment. They must be involved in health planning and monitoring so that they won't sit there and loaf. You cite the health center, they will not come. They say no be we put am o, I no fit go for that village. No, we no dey go there, we no dey cross this bridge. We must get them to plan together and work together to ensure service delivery. I'm sure you know that in primary healthcare we have ward development committees to work on it. Primary, the local government is involved to ensure that at the very ward level, people are involved in managing their health system. Then we improve the health system by planning and management at the local government level. We make IMCI medicines available. We have developed the essential medicine list so that at all levels, people will be able to have the medicines the children need. They also need to organize work. You see, one health worker cannot open card, weigh the children, take the temperature, give the medicine and so on. So several people need to be oriented. The person who open the card, the person who weigh the children, the nurses, the doctors, the pharmacists, the community health officers, all of them have to work together to ensure the system works well. Then we need quality improvement and supervision. Don't say, oh, the nurses are there and you are not checking. Well, when they are weighing children, check, are they weighing correctly? Are they charting the weight well? Are they measuring the temperature well? What of the referral pathways and services? You know, like in some states, they have emergency ambulance services so that When children need to be moved from one place to the other, there is a way to move them. The health information system and the health sector reform must all work together to improve the health system for quality service delivery. And when the child is referred by IMCI from primary health care to secondary or tertiary level, there must be effective communication so that patients that are referred do not suffer various levels of delays. They are able to access quality care at the level they are referred to. Then the third skill one is improving the health workers' skill. We talk about case management guidelines and standards. In Nigeria, we have recently updated the case management guidelines. So we had the 2019 guideline, but it's 6 years now. So we have updated the guideline to reflect current realities. We must train the people using facility-based healthcare providers. Then the primary healthcare providers can also be trained, but we must maintain the competence of the health workers by monitoring them, ongoing supportive supervision, visiting them, follow up after training to ensure that the skills they have learned, they do not lose it. And that is where we used to have challenges. So now it has been resolved at the national level that any person that wants to support the country with IMCI training must include follow-up after training, so that follow-up after training visits, so that we'll be able to ensure that the skills we have acquired are being used at the facility level. So the case management training is just like what the hospital workers do. They must assess, the objectives is to help the health workers to assess, classify, and treat children accurately following case management guidelines. They have the guidelines, the chart booklet, the notebook, so that the assessing means taking a history, examining the child to pick up the key signs. Then you categorize the children. You don't make diagnosis based on the signs. You categorize, you classify the children, then you identify the treatment you are going to use, and you treat the children adequately. Then some children need pre-referral treatment, that is those that have to be taken from one level to the other. You need to treat them like a child who is convulsing. You have to put the child on anti-convulsant, treat the child to stop the convulsion with either rectal diazepam or paraldehyde and so on. So you give the child that pre-referral treatment, ORS, antibiotics, anti-malarials, so that the child can arrive at the next level of care without dying. Then you counsel the health workers, caregivers about home care, including how to give medicine, what signs to look for that indicate the child should be brought back immediately, and when to return to the facility for follow-up. Then you must check, when you look at that, you must check the child's immunization and vitamin A supplementation, carry out feeding assessments, check for anemia, and then give the nutrition counseling for the mother. So they use the wall chart and they use the chart booklet. The chart booklet is divided into the children 0 to 2 months and then 2 months to 5 years. So the different modules are there. When you are going to be trained, you will see the modules and understand it. So there are two things you must do. You check every child for what we call general danger signs, which are not able to drink or breastfeed, vomiting everything, convulsions, lethargy or unconsciousness, and looking for the child convulsing now. You also you must check every child for malnutrition or anemia, because I've told you malnutrition contributes to 45% of under 5 days, and a malnourished child, you have to review the medicine, the feed therapy, so you must pick up such children. Then you must check for HIV infection, the immunization status of the children, vitamin A status, and check the health of the mother. Then there are things you must ask about, the main symptoms, the things that contribute to death, cough or difficult breathing for pneumonia, diarrhea, fever, ear problems, and other problems. Sometimes the child may present with problems that are not within IMCI. So we don't just train anybody on it. It must be a health worker that already has some basic knowledge about medicine, about healthcare, like community health workers and so on. Doctors, nurses, we must train them, because a child may come in with interception, a child may come in with congenital malformation. These ones are not covered by IMCI. Manage the child essentially as expected. Then you classify the child using the symptoms and signs obtained, and then manage the children. But you must note that children with general danger signs should be quickly assessed for all symptoms and signs, given pre-referral treatment, and urgently referred for inpatient care. Then the mother's health. So the categories are in three. The pink one shows a child that is severely ill and needs urgent pre-referral treatment. So you treat the child and you refer, you don't delay. Then the yellow ones are children that need specific areas, ORS, you identify them, you manage them. Then the green one are those who the children have come, but you have assessed they are not really very sick, they are doing well. You now give them supportive care, breastfeed your child, keep the child warm, come back for growth monitoring, for immunization, and so on. So those are the three categories that we use in the IMCI. Then in improving the health system, we must address medicine availability, planning and management, organization of work, health information system, and reform, because we must get the health system to function before IMCI can work well. That are the things we have discussed. Then at the community level, we must integrate it and integrate the following things. You can look at this is like community level activity. We must improve partnership between the health facilities and the community. So the health worker cannot be the chief in the hospital. He does not know what happens. The community people are there. She must be able to interact with the community, talk with the women, attend their meetings, go to church, go to mosque, find out what is happening. My youth don't come to hospital. Where do you deliver? What of the TBS? What you must meet with them and get them to have confidence in the health facility and be able to work together. So once you go to a facility and the community people don't know the health worker, that doctor we no know am o, that means that component is not working well. Then the second one is increasing appropriate and accessible healthcare and information from community-based providers. So all those people in the community, like pete medicine shop, we must train them to have simple things like ORS, anti-malarial, paracetamol, and so on, so that when we prescribe, they can go there and they can also refer the patient. We must get them to work well. They shouldn't go and start setting up IV line, doing termination of pregnancy, giving intravenous antibiotics. No, their help is to help the mothers to go appropriately to seek for care and guide them, like teaching her how to use ORS for diarrhea, anti-malaria, and refer the patient. Then the third component is integrating promotion of key family practices critical for child health and nutrition. So those are these ones. I'll show you: breastfeeding, hand washing, sleeping under insecticide treated net, for agriculture. So to optimize the implementation of IMCI, several other sectors must be brought in: provision of water, the local government, education, there must be fund, there must be agriculture, and the families must be united so that the systems can effectively function to help the child to work well. So you talk of element 1, 2, 3. Those are the ones I have talked to you about. And so community IMCI is important because many children die at home. Children did not reach hospital. So it helps the women and families to start taking care of their children. And trained health workers may not be available or readily or unaccessible at the time many children are getting sick. And appropriate feeding can reduce child death by 13%. Breastfeeding, the improved complementary feeding can prevent death from diarrhea, respiratory infection, and measles. Good hygiene and hand washing can reduce diarrhea by 10%. So several things can be done at the community level to improve the survival of children. So you can see these are studies from 3 countries, Kenya, Tanzania, Benin, that 50 to 46 to 80% of deaths in under fives occur at the home level. You can see it, and then the rest occur in the facility. So if you are able to improve what happens at the home level, fewer of the children will die at the facility level. So I have talked to you about, so these are the key household practices: growth, promotion and development, exclusive breastfeeding, complementary feeding, adding breast milk, food to the breast milk, adequate micronutrients through diet or supplementation, growth monitoring, promoting mental and psychological health, psychosocial development, and birth registration. Then home management: when the child is sick, there must be essential newborn care. Continue to feed the child and offer more food when the child is sick. Give appropriate home treatment for infections like malaria, diarrhea, and when antibiotics should be. Then you take the child, take appropriate actions to prevent and manage injuries and accidents. Children should not be left alone. Some safety should be stored away. Sharp objects should be kept away. The children should not face the risk of electrocution. People must take care to make the home environment safe for children. I'm sure you heard of that, is it Davido or one of those celebrities whose child drowned in his swimming pool? So we need to be careful at home. So we also need to prevent diseases by proper disposal of feces, hand washing, making the children sleep under insecticide treated net, prevention and care of HIV/AIDS. One thing that has worried me is that we are seeing many young people coming with HIV. That means they are not testing themselves. Some young girls and boys are sexually active with unprotected sex occurring, and they are getting infected. So we have a lot of problems. We also have child abuse and neglect, and we must take appropriate action to protect the children. If you drive out this night now, you will see several street children that are neglected, children with injuries that are being abused. So we must take holistic care to protect children. Then when children get sick, we also need care seeking and compliance in the facility. The child must complete the full course of immunization before the second year of life. We must recognize when the child needs treatment outside the home. A child you have, like one lady met me with a child that was wheezing. They say, "Oh ma, the child, you came to me in church with a wheezing child. What am I supposed to do?" I had to send them to the hospital. They went, the child was nebulized twice, and the child recovered. So they must know when to go to seek care. Imagine instead of going to hospital, coming to church to call me, "Ma, my child has fever, my child convulsed. What will I do in the church?" I don't come for treatment in the church, I come to worship. So such people, we must educate them to go to where care can be given. Then they must follow health workers instruction about treatment, follow up and referral. Some people, if you refer them, they turn back, they go home, they go to native treatment, go to TBS or other people until the child is very sick and comes to die, and it's an avoidable death. People must prepare for birth. Some people come to labor ward, nothing, no money, no dress, no emergency preparedness. At least most women will deliver safely, but 15% of them can have unexpected situations arising. for which they may need referral, they may need cesarean section. So as you get pregnant, we must teach the women to start saving money for that unexpected occurrence. The baby may need admission, the woman may need admission. They shouldn't come and say, I no get anything, and then get the children to die. Then the men, we must provide essential community newborn care and get the men to be actively involved in child care and reproductive health activities. It should not only be the women that should do family planning, and then the man will go and have child from wife A, woman B, woman C, and then the man say, no, doctor, I no go do family planning. If I do, my organ will go get another pikin. They must be involved in family planning. These are the details of those practices. Now, diarrhea, pneumonia, and malaria. So that is also part of community IMCI. So IMCI can only be implemented well within the umbrella of a functional primary healthcare system. So we said that the primary healthcare remains the first level of care in Nigeria and most other countries, and it should be the Alma Ata Declaration and the National tell us how we should implement it and how we should work. And the World Health Report shows that it is still relevant. The PFC reforms have addressed it. So the IMCI is implemented within this umbrella, and we need to train many more health workers to be able to deliver on the dividends of childcare and improve their survival. The coverage of implementations is still poor, so we need to ensure that the rights of children to equitable and quality healthcare is ensured. The materials are reviewed and developed to ensure that they are up to date, and we must link the primary care with the secondary care facility so that the care will not be interrupted and women will still get the quality of what they have to get. And the obstacles like lack of funds, transport, no health worker. Thank you very much. Hello? Have I lost you people?
No, ma, we are here.
We are here.
We are active, ma.
Hello?
Our energy is
We are
very
active,
high.
man.
We are here, ma.
We are active, man.
Very active, man.
We're here, man.
Thank you.
Thank you, man.
Okay, so we say I
Thank
give
you,
out
Prof.
welfare. Yes, National Program on Immunization, Child Survival, IMCI. I hope I've been able to cover all those topics. So
Yes,
I will
yes,
send
ma'am.
the
Thank you very much.
lectures as soon as I
Ma, we are following
get
you.
I don't know if you have questions to ask.
No, ma.
Question, I know
Thank
we
you
have
very much.
passed it.
Just the lecture slide, man. The lecture slide, man. The lecture slide, man. Thank you, man.
I have a question, ma. Please, ma, at what age
Oh,
is the baby is supposed to start school?
go
Since we are
ahead.
to breastfeed for 3 years.
Know the age. The child can go to school with express breast milk. They are not supposed to go to active school. Actually, in many countries, children start school at 6 years. So that 0 to 5 years in nursery school, schools are supposed to be close to where the mothers are so that they can go breastfeed the children and do all the things that the children need to hear to get to well. So the children should not start school too early. The early child care services are up to 3 years, but before 2 years, a child should not go to school. The mother should breastfeed. I know many people already start. The crèche services are supposed to keep a child close to where the mother is working. If she's going to the market, there should be a crèche in the market. We have opened crèche in the secretariat, in teaching hospital, in BM, so that workers will come with their babies and put them there. They rest, they play, they develop while you go to work. But now, because women have to work, they are all actively sending their children to facilities where they leave the children. Unfortunately, in some of those facilities, they give them medicines to make them sleep. They use infant formula, feeding bottles, all manner of things to take care of the children and increase the mobility of the children. I remember the pathetic story of a child that was about 9 months old when the mother sent her to a crèche because she was either working or going to school. The husband was busy. The child got infected with tuberculosis in that crèche and tuberculous meningitis, and the brain was damaged. And up till today, the child is not well. And they had to, the father seeking, maybe they were feeling guilty, they had to go to relocate, and the child is in care services in one of those countries, but the child's achievements have remained suboptimal. So we need to really make a choice. When we have children, you can go to look for a crèche, and the Child's Rights Act, the child health policy, and then even the food and nutrition policy of the country indicate that children should be breastfed and that crèches should be open so that women can have proximity to where the children live and be able to breastfeed their children. So if we decide to breastfeed, you can do it. Take the child to work and then express the milk. Instead of giving the child water, put the breast milk inside the container. Breast milk can stay outside the fridge for 6 to 8 hours. The crèche is just for a short period of time. You should carry the children. But this time we see children who are kept in school from 7:30 till 5 p.m. That is an abuse. The children are young, their immunity has not developed, so we must minimize the stresses we expose them to ensure that they do not suffer. Thank you.
Thank you, ma'am.
All right, ma. Thank you, ma. Thank you very much, ma.
Prof, this one more question.
Okay.
Is it safe for a pregnant mother to breastfeed
Thank
the child?
Very safe. Yes, she should breastfeed till the new baby comes. But usually, if a mother does exclusive breastfeeding, she will not see her period for the first 6 months. Then, between 6 months and so long as she's doing optimal breastfeeding from 6 months and go, many women, so long as they are breastfeeding, they will not have menstruation. But once her menstruation comes, she should have a safe family planning service delivered to her to ensure that she can still breastfeed and protect herself. But if the woman is highly prolific, she can still get pregnant during that breastfeeding period. So what does she do? The breastfeeding does not affect the baby in the womb. So allow both of them to grow together. Breastfeed this one and carry your pregnancy. Only you have to rest more and take more time, because many women suddenly stop breastfeeding and increase the risk of the child getting kwashiorkor, and that is how the name came forth. In one of the health centers I went, the mother, young woman, she had a 3-month-old baby, and then she had a baby that was about 2 years, 2 years, but that meant just a few months after the birth of the other baby, she got pregnant. She could neither take care of this 3-month-old nor the older baby. All of them were malnourished. I wanted to send them for admission. She said, oh, her husband was a carpenter or mason. He has gone to work. So there was no resource to manage themselves, and yet they were exposing themselves to that high risk. Even among the rich, getting children at short intervals increase the morbidity to the mother and the risk of death to the children. So safely, the birth space is a part of the child survival strategies. Birth should be spaced about 2 to 3 years apart so that the mother fully recovers from one pregnancy before going to the next one. Okay, so
Thank you, ma'am.
breastfeeding is
Please,
safe.
one more question, ma.
New more baby is born, both the old baby and the new one can breastfeed as twins and continue.
Thank you, ma.
And the breastfeeding too is safe. Hello, a man can still sleep with his wife while she is breastfeeding the child. So don't say because the baby is being breastfed, the husband should not have access to his wife. We must allow them to have their normal relationship so that we don't break up the family. The semen will not enter the baby's ear, will not cause infection. So we should understand it. Thank you.
Thank you, ma.
He
Okay,
says
please,
it's
ma, one more question, ma.
okay.
One more question, ma,
Go
please. Okay, ma. When you are, I want to ask question in respect to this breastfeeding, please.
Yes.
For sometimes you will hear some mothers complaining that their baby are crying, even if they feed them, do breastfeeding for almost 12 times in a day. They are still crying that like they are not the children are not satisfied with the breastfeeding. So what should be your advice, ma'am?
Okay, babies cry for a number of reasons. Number one, I have told you that when there is poor positioning and attachment, the baby will not be able to suckle effectively. So we need to help the baby to hold a reasonable part of the areola into the mouth and suckle. Baby should not suckle from the nipple. Milk will not come out well. This lecture is too short to explain that detail to you. But baby may not be well attached. You know, if you turn your neck to the right or to the left, you will not get as much breast milk as if the child is looking straight. Then the next reason why the child may be crying, maybe the child needs to be comforted, the child needs company, the child needs relationship, the child may be weak, the child may be sick. There are so many reasons, but we always want to offer breast milk first. If it is breast milk, the child will improve. But once you offer breast milk, the child is still crying, he's not happy, you should look beyond the breastfeeding and see what else is causing the problem. Like last week, yes, last week Wednesday, I admitted a baby. All the mother came was that the baby was crying too much. The baby didn't really have fever, but you know, new babies, it was about 2-month-old child, they can have high fever or low body temperature when they have infection. So all the mother said was that baby was irritable, was crying too much, was not wanting to breastfeed. So we looked at the baby, told her the baby had sepsis. She had started some antibiotics at home, Fleming syrup, so it didn't allow us to culture the organisms. But when we put the child on antibiotics, it took about 1 week for the child to settle down, and yesterday we discharged the child. So breastfeeding alone is not the solution for a child that is irritable, unhappy. We must diagnose the child appropriately and offer the right treatment. Okay?
Thank you,
Hello?
ma.
Okay,
Thank
thank
you,
you, ma.
ma.
God bless you, ma. Good night. Thank you, ma.
Okay? So
All right,
thank
ma.
you very much. I
Thank
will
you, ma.
send the
Thank
link.
you,
Ma.
Please, I have a question now.
Okay,
Thank
go
you, ma.
ahead.
Thank you,
Hello,
ma. Good
Prof.
night.
Yes, go ahead.
Okay,
Today,
my
Joe.
question is okay. I'm so concerned about breastfeeding mothers. You know, at times when they put to bed and the breast milk isn't coming out, and then how can they boost their breast milk?
Okay. Now, breast milk is not coming out because you are not feeding frequently enough. You
Yeah,
must
ma.
feed, and if the baby is not suckling well, you have to learn to express breast milk. The only way you can boost breastfeeding is to stimulate breastfeeding. Sit in good position, have good thoughts about your child, have less stress, no stress. You know, if you say, hey, this is a fifth boy I'm having, all those other boys are very naughty boys, now boy again, that one will make you reject the child. You cannot breastfeed well. Or if it is a girl, but if it's a girl child you desire, you're happy, you didn't want to get pregnant, all those emotional stresses, there is no money, my husband is this, all those things will affect the woman's ability to breastfeed. She must have loving thoughts towards her child. Then you must breastfeed a minimum of 8 to 12 times a day, both day and night. So if you are too busy, you go to work, breastfeed once in the morning. If you go to work, you should find time every 2 to 3 hours, go to somewhere, express the breast milk, put it inside the container and bring it. You can stay for 6 to 8 hours in the house, in the container, without getting spoiled. So the mother must stimulate herself to breastfeed. Give yourself breastfeeding time, feed the child regularly, and ensure that the baby is breastfed on demand and uninterrupted until the baby releases the breast. If the mother is not producing adequate milk, the mother should come, we will check. Sometimes they think the milk is not adequate. If a mother is exclusively breastfeeding the child, to know whether the milk is adequate, she must breastfeed at least 8 to 12 times a day, and she must spend at least 30 minutes on each breast. And you use both breasts, so you spend like 1 hour. So if you breastfeed for 10 minutes, it will not work. You must pay attention and breastfeed the child well. Then if you are breastfeeding well, without giving the child water or anything, the child should make urine at least 6 times a day. But you know now we are using highly absorbent diapers. So if you want to know, remove the diaper and check how many times is the baby making urine. At least 6 times. The urine will not be concentrated, and then the child will get at least 500 grams every month. So a child who was born with a weight of 3 kg, by the end of the month, the child would have gone to at least 3.5 kilograms, showing that he's gaining weight. So if you are concerned, you come to the hospital. There are people that are trained to be able to investigate what the problem is and counsel you. And when a mother is sitting to breast, you should support her back, because if she sits bent, she will be tired. She can lie down to breastfeed. She should raise her feet so that she really gets a lot of comfort. There are no lactogogues. Nothing stimulates breastfeeding except this thing. So you cannot go and take palm wine, take pepper soup, take this. You should only eat to satisfy your hunger and drink to satisfy your taste. But don't take alcoholic beverages. Don't take palm wine. Those drinks make the baby to be intoxicated. They cause diuresis in the baby. Baby urinates more often, and so baby will continue to lose weight. Thank you.
Okay, Prof, thank you. Sorry. I spoke with somebody, but I don't know how true this thing is. I learned that breast milk is being sold in the hospital as well. Just the way they have blood bank, they also have a breast milk bank for maybe people that have a multiple children.
Yes, there is breast milk banking, but it should not really be sold. When we do the breast milk banking, you go to women who are breastfeeding, you collect their milk. They usually give it free in those countries. Then you put it in a bank, but the requirements for running a breast milk bank are a bit challenging in our center. That's our problem, because you must have regular light. You must have women that are willing to um donate the breast milk. Then when the milk comes, you test it, to be sure the mother is not infected, like with HIV, hepatitis and so on. You test the mother before you collect the milk. Then you must also work on the psyche of the community. When we were trying to introduce the concept, people told us that no, if a child shares breast milk with another person, they are like brothers and sisters. And there was a patient that we helped to give breast milk when her child was sick. So because she sucked breast milk from their child sucked breast milk from another woman, every time the child saw the children who were the original owners of the breast milk, the mother would say, hey, look at your brother, look at your brother, because they suck. So that can affect the acceptance of donor breast milk. So we need to work on the community to make them accept that just like they take blood, taking breast milk from another mother is nothing, and it is helping your newborns, preterm babies who would have died because their mothers were sick or dead. They can get this milk from other people and be able to survive. There is a question here that Okay, which position is best? Thank you. And she said they are tired. Me too, I'm tired. But any position that is comfortable to you, sitting down, lying down, choose it. And it's not fixed. Anywhere you are, if you are very tired, lie down. The baby will breastfeed. You won't kill the baby. If you want to sit and support your back so that you breastfeed properly. Thank you very much and good night, so that others will go. Thank
Good
you.
night.
Bye.
God bless
Good
you.
night, Prof.
Thank you,
I have
Prof.
Good
a
night,
Thank
question.
Prof.
you.
I have a
Thank you for the
question.
lecture. Prof,
Good
I have
night,
a
ma.
I will
I have a
send you
question.
the
I have a
link
question.
Good night, man.
Thank you, ma. Good night.
Leave Prof alone. No more question. Let Prof go and rest,
Please,
please.
I ask you, ma.
Oh, I have a question. Oh, Prof,
No way.
very
Prof will
important.
not answer it.
Let me
Very,
continue. Let me
Prof,
continue. Ask your
very
question.
important.
Ask your
Ask the
question.
question I want to hear.
No question.
The question I'm listening. Two people, one person said they are tired. One person says it's 3 hours already. So if you people accept, you can ask the question.
Please ask
Prof,
the
the
question. We
ask the
cannot be tired. Question.
What is the question?
Postpartum vitamin D.
There's no
How can
question
mothers
again. There's no question again, ma.
Okay. If you have questions,
know how to
get my contact from your prefect and send the question to me. I will answer. Meanwhile, thank you very much and God bless you. Sorry it took us a long time because they gave us too many
Good
topics
night,
to
ma.
cover within a short time. Good night.
Thank
Thank
you,
you.
Prof.
Thank you,
Sweet
ma.
dreams.
Thank you, Prof. Have a
Thank
good
you,
night
Prof.
rest, ma.
Thank
you,
you.
ma.
Thank you. Good night. Bye.
Bye.
Bye, ma.
Bye. Sweet dreams.
Bye.
Bye.
Esiere.
Serende. Kachifo. Egwiwule.
Kachifo.
Yes,
Good night,
yes,
ma'am.
yes, ma.
Esereo.
Ma.
Esereo. You are too active, ma. We love you.
Thank you very much. I love you too.
Very active and strong, ma. More
Honestly,
energy, ma.
Good
more
night.
grease, ma.
Thank you.
Very interesting lecture. Good night, ma'am.
Well, too many topics. They should allow us take one or two and talk. They gave you too many things, but you are going to read a lot to fully follow. Anyway, you are already exposed to health, so I think they are just trying to give you some updates.
Thank
Yes,
you,
that's
Prof.
true,
Yes,
ma'am.
God
ma.
bless
Thank
you.
you. Good
Yeah.
night.
Bye.
All green.
Bye, ma'am.
Bye, ma.
I will be the last person to log out. Cause no cut this thing.